discuss on more case basis as well as some more insight about insulin. For the first session of the day, I would like to invite our moderator, Mr. Malay Parikh and Dr. Kaumudi, to introduce our first speaker. Is Vidisha is there?
She hasn't joined, sir. We'll do the introduction.
So Kaumudi and Malay, please take forward.
Yes.
Good morning, all of you. Hello. Thank you so much, Dr. Vipul sir, for nice introduction. So now I am going to introduce our first speaker, Dr. Dharmendra Panchal sir. Sir has MBBS done from BJMC Ahmedabad. He did his MD medicine from NHL Medical College Ahmedabad. He is a chairman of Dr. Diabetes Digital Diabetes Care Program. He is a diabetologist from Diabetes Sabarmati Ahmedabad. He is assistant professor diabetes and endocrine, Dr. M.K. Shah Medical College Ahmedabad. He is consultant endocrinologist at Gujarat Cancer Research Institute Ahmedabad. He is member of AMA, IMA, RSSDI, EASD, ISPED, ADA at various national and international lobby. He is a regional faculty for certificate course in evidence-based diabetes management CCBDM by PHFI. He is a regional faculty for advanced course in diabetology by RSSDI. He is an invited speaker at various national and international conference, and he has published various papers and written chapters in national journals and textbook as primary and co-authors. So over to you, sir.
Thank you, Malay, for the kind introduction. Again, a very warm welcome to all of you on the day 2 of Insulin School and initiative by our own Dr. Bansi Sabu sir, and well coordinated by my senior Dr. Vipul Chavda. Thank you all for involving me in this. And what I am going to speak is on monitoring of the patient on insulin therapy. Why we should monitor blood glucose? Of course, because of recommendation of various international and national bodies. Yeah, it has power to prevent hypoglycemia and hyperglycemia. It gives an idea how our lifestyle, food, exercise can affect. It can give us an idea whether whatever the patients are taking, either insulin or other medication, they are working or not. Ultimately, to reduce the risk of developing diabetes complication, it is necessary to monitor, and that's why we monitor. From ancient time to modern world, various method, various technology of glucose monitoring has been developed. Initially, until today also, many patients, particular type 1 parent, give the history that baby was peeing and we saw the ants, and then we think of that maybe glucose and we go to the doctor. So, and today's era where we have continuous glucose monitoring available, if we go to the history, it was early in 20th century where laboratory testing for blood glucose was developed. In 1945, clean test tablet developed for urine glucose testing. 1957, were clean sticks, that deep and read method. And 1965, it was the first glucose strip available. 1970, first glucose meter for doctor's office use, and it was weighing 1.2 kg. Just you can imagine. In mid-1970, where SMBG was contemplated, and UK PDS DCCT in 1990, and they confirmed the benefit of self-monitoring of blood glucose. In 1980, first glucose meter with using enzyme electrode was developed. And over the last 40 years, these glucometers have become smaller and smaller and smarter with more ergonomic design. Lenses are becoming smaller, less painful. Reagent strip using a bit amount of blood only. And since 2000, continuous glucose monitoring systems are available, primarily for patient with type 1 diabetes. Now it has expanded its use in type 2 diabetes as well as in pregnancy also. If we talk about self-monitoring of blood glucose, it gives a real-time glucose measurement, detects hypoglycemic episodes as well as hyperglycemic excursion, and it's immediate, instant feedback, immediate treatment decision can be taken, and it is helping to fine-tune the therapy, involves the patients actively, and of course, very safe to use. So one of the basic pillars for monitoring, self-monitoring blood glucose what should be the frequency? Optimal frequency of SMBG depends on what type of diabetes you are dealing with, what is the level of glycemic control, what the target we want for glycemic control, what management strategy has been employed, which are the individual patient factors like acute illness or change in habit, change in foods, shift in location. But in general, SMBG should be carried out 3 or more times for the patient who are on multiple daily injection or insulin pump therapy. Now, using the technology with telemedicine, like using smartphone software for adjusting the basal bolus dosing, factoring the blood glucose monitoring, involving diet and physical activity parameter, it is giving much more result, much more improvement. You can see here the blue bar where patients were having only paper logbook and 3 and 6 month follow-up. With red bar, you are having diabio with 3 and 6 month follow-up, but no teleconsultation. And when teleconsultation every 2 weeks was added, a drastic response, good response in terms of reducing HbA1c and persistently low HbA1c target was achieved. So, and along with SMBG, if you involve technology and telemedicine, of course, we can get the good result for our patient. And more you measure, more you are in your goal. So there was shown in correlation between HbA1c level and number of SMBG. Higher the number of self-monitoring of blood glucose, you are going to achieve your HbA1c target. You can see HbA1c target of 7. If you want to achieve, in general, 4 to 5 times self-monitoring blood glucose is there. Yes, it improves glycemic control. Either you are employing or you are doing self-monitoring blood glucose in type 1 diabetes, type 2 diabetes with only lifestyle, type 2 diabetes with OAD, or type 2 diabetes with insulin. Anyway, if a patient is adherent to self-monitoring blood glucose, he is bound to achieve good glycemic control as compared to the non-adherent with self-monitoring blood glucose. And not only we want to achieve the target, we want to reduce the morbidity and mortality. And that is also evident from Rosso study, where a person or a people or a group on self-monitoring blood glucose were having low morbidity and low mortality, as evident here in this graph. But it has its own limitations. At lower plasma glucose level, imprecision of reading becomes more important. It requires training and willingness of the patient. Finger prick is required to operate the blood glucose meter. Sometimes a patient might be not able to cope up with the technology, right settings. Interpretation of the result is also much more important. So it has to be, put on in that manner so that result we can get the outcome of that. Accuracy, it is device dependent, user dependent, but nowadays we have the smart glucose meter which are much more accurate. So for some patient it might not be feasible. Next is glucose blood ketone testing. Yeah, of course, particularly in type 1 diabetic patient or those patients who are on insulin therapy, this blood ketone testing becomes important. And ideally, we should educate the patient to do it if they are facing a hyperglycemic excursion and to keep it less than 0.6. Then the era of HbA1c. Today, for the patient monitoring, it's a main glycemic matrix based on which we decide the therapy of our patient. We decide the change in the treatment regimen based on HbA1c, one of the gold standard for glycemia measurement. For physician, yeah, it's a diagnostic criteria for diabetic people even, and target standard used in diabetic algorithm to modify the therapy and set up the new trials. For various regulatory authority like FDA, EMF, PMDA, it is one of the major outcome marker for the glucose lowering drugs and technology for diabetes management. Long way ago, DCCT has established the importance of HbA1c, and lower the HbA1c, you lower the microvascular complication. Particularly, you can see here, lower the HbA1c and progression and onset of retinopathy is delayed. But same HbA1c with different risk, there might be hypo and hyperglycemia and HbA1c may not be able to reflect the same story. So HbA1c doesn't tell us the full story. You can see here a person with 7% of HbA1c with average glucose of 8.6 millimole per liter, but he might have different glycemic variability, and that's why we need to look beyond the HbA1c, because HbA1c has its own certain limitation. Alone, it is not able to guide the improvement. It is not able to identify hypoglycemia or glycemic variability. There are some problem with accuracy in different assays in people with hemoglobinopathies or iron deficiency anemia, CKD, liver diseases, and individuals has own RBC lifespan, which varies from in different race in individual, and various genetic factors also affect the glycation of RBCs. So HbA1c alone doesn't tell us the full story, and that's why we need to look beyond the HbA1c, and that is what nowadays we look for time in range. So what is time in range? It's a percentage of the patient within the glycemic range of 70 to 180 milligram per deciliter. Evidence suggests that TIR is inversely correlated to the risk of developing vascular complication in people with diabetes. TIR may be used as an appropriate clinical endpoint in diabetes research and a measure of glucose control in patient, and going beyond time in range can lead to hypoglycemia or hyperglycemia. We call it time below range and time above range. So if we compare HbA1c and time in range, so HbA1c is a single value, while time in range, it evaluates a continuous glucose level. HbA1c compares every 3 months. Here, any time period, you will have the trends in the person's glycemic parameters. In HbA1c, we are not able to record hypoglycemia, hyperglycemia variability, which is reflected by TIR. Immediately, TIR defects the acute effect of therapeutic changes and, more important, patient-related outcome, which has a good correlation with time in range, where it is not with most of the time in HbA1c. In various clinical trials, time in range has been validated by its association with microvascular complication. It has shown that for each 10% lower time in range, retinopathy progression is increased by 64% and microalbumin outcome by 40%. So it is validated, and it is also associated with carotid intima media thickness in type 2 diabetic patient. You can see here for patient with abnormal CIMT percentage are higher if you are having time in range below 40, and more time in range, lesser percentage of patient with CIMT is there. So of course, it has its own relation with the complication, and that's why it is beautifully mentioned as a CGM matrix clinical core, where the target is given in type 1 and type 2 diabetic patient. Time in range should be 70% or more, though it can be relaxed for a person with in children if age is less than 25, or if you are keeping by willingly goal of 7.5%, you can set time in range to 60% or above. In older or high risk individuals, time in range can be set 50% or above, but here time below range should be again less than 1% to save the patient from hypoglycemia. In pregnancy, type 1 diabetes, again, time in range is mentioned to keep it more than 70%. And it is now employed in gestational diabetes even. So CGM continues data, trends, and pattern. We can identify more accurately. We can correlate it with patient's lifestyle. There are warning alarms for patient rapid blood glucose changes, and it will be enough for the patient to react and correct that pattern. And of course, psychological benefits. Okay, my system is going to take care, so I can sleep well. But again, it has coming with its own limitation. It can be worn temporarily. Wearing can be uncomfortable. Insertion site reaction, loss of transmitter, cost, one of the major issue in our country. And each manufacturer has different format for displaying data, so it may be confusing. Sometimes complex interpretation is there. So it is also coming with its own limitation. Nowadays, this continuous glucose monitoring is employed in various clinical trials as well, which allows us to see the time the patient in normal glycemic range, and it allows to measure the glycemic variability, which is itself an independent risk factor for multiple complications. And at last, let us review all the guidelines and recommendation. This is ADA Diabetes Square Standard of Care 2022, where it says that at least twice a year HbA1c has to be performed, and glycemic status at least quarterly and as needed has to be performed. Ideally, in general, keep the goal of HbA1c less than 7, pre-prandial capillary blood glucose 80 to 130, and peak postprandial capillary blood glucose less than 180 milligram per deciliter, but it should be individualized as per the patient status, disease duration, life expectancy, associated comorbidities, established complications. HbA1c, as I said, one of the gold standard, but it should be adapted as per the requirement of patients as well as physicians' recommendation. And keeping HbA1c less than 7% has been associated with the low risk of microvascular complication. SMBG, 3 or more times daily in person on multiple injection or insulin pump, less frequent injection, non-insulin therapy or MNT alone. It is useful to guide the management to achieve postprandial glucose target. Postprandial SMBG may be appropriate. So to employ whether 7-point SMBG, 4-point SMBG, or twice a day SMBG, or focusing on postprandial blood glucose as per the patient status is recommended. CGM with intensive insulin regimen is one of the useful tools for lower the HbA1c in type 1 diabetic. Evidence for lowering HbA1c less strong in children, teens, young adult, but CGM associated with SMBG, we can achieve the lesser target HbA1c without hypoglycemia even. So it can act as a supplement tool with SMBG in those with hypoglycemia unawareness or frequent hypoglycemic episodes are there. So it's not a job of patient only to do glucose monitoring. It's not a job of healthcare professional only. It's a whole diabetes care team approach where combined synergistic effort of the whole team, which are crucial for effective monitoring of the patient who are on insulin. So with that, I would like to thank again and will stop my sharing. And if we have any comment, suggestion, or question, we can go ahead. Do we have any things to discuss or any comment from Dr. Vipul, Dr. Kamudi?
Thank you. Thank you, sir. Actually, there are no questions yet. We can discuss the questions at last, at the end of the session.
Monitoring is actually a pillar for the management of any non-communicable disease. And I saw Dharmendra is very passionate about monitoring, and he has delivered an excellent talk. So we all should enforce monitoring in all our patients. Thank you, Dharmendra, for a wonderful talk. We will discuss in the later part. Please, Meet, introduce the second speaker.
Thank you, Dharmendra. The second speaker for today is Dr. Meet Shah. And he's going to speak on in-hospital hyperglycemia in ICU and NICU.
Okay. Thank you, Kamudi.
Oh no, Meet, I'll introduce you. Wait. Dr. Meet is MD General Medicine from BJ Medical College, Ahmedabad, and MBBS also from BJ, Ahmedabad. He is a full-time physician and diabetologist in My Life Hospital, Kalol. He's worked as a fellow in Advanced Course of Diabetes at Diacare Center, Ahmedabad, under Dr. Banshi Sapu. He's worked as a registrar from 2017 to 18 and an intern at the hospital from 14 to 15. So he has presented Association of Essential Hypertension with other comorbidities in patients admitted at our tertiary care center and also got first prize for the same. And he also has presented a poster, a rare case of paroxysmal nocturnal hemoglobinuria PNH, and it has been selected as one of the best 25 posters at GIC 2017. Over to you, Dr. Meet.
Thank you, Kamudi, for kind introduction. I'm sharing my slides. So everyone can see the slides?
Yes, yes.
Okay. So thank you, Bansi sir, as well as Vipul sir, for giving me the opportunity and making me the part of iSchool. So the topic is in hospital hyperglycemia. Definitely, we have a COVID patients going on, and there is a lot of use of steroids. So in hospital hyperglycemia, we have to tackle it properly. And so this is the really important topic in today's scenario. So I will cover up definition, classification, impact on clinical outcome, management in the ICU setup, management in non-ICU setup, discharge plan, some miscellaneous things, and then summary. So what is the definition? It is defined as a blood glucose level more than 140 milligram per deciliter. If the blood glucose is more than 140, it should prompt a certain is persistently more than 180. Persistently means you have to check the sugar twice. One reading is not enough. So if the sugar level is more than 180 twice, then insulin is recommended. So cutoff is for hyperglycemia, cutoff is more than 140. But if it is more than 180, then we should start with the insulin. So then comes the classification of inpatient hyperglycemia. So you see the patient is having more than 140 sugar, get the HbA1c. After getting the HbA1c, we can divide them into the three categories: previously diagnosed, previously undiagnosed, and stress hyperglycemia. Previously diagnosed, they are already diabetic patients, and then they come up with hyperglycemia. Previously undiagnosed, they were not diagnosed, but when you get the HbA1c is more than 6.5, and then they are having hyperglycemia as well. So hyperglycemia in the previously undiagnosed diabetes, that is the second category. Third category is stress hyperglycemia, where you find that patient comes up with high sugar, but HbA1c is non-diabetic or in the pre-diabetic range. This is the third category, stress hyperglycemia, and here sugar can revert back to normal after the discharge. So this is the three primary classification which we can get it based upon HbA1c value. So the question comes, does inpatient hyperglycemia affects the clinical outcome? Answer is definitely yes. And we can get this answer from this study. This study was published in 2003, JS Mayo Clinic, where they enrolled about 1,800, more than 1,800 patients. They were enrolled in the ICU setup, and they correlated the sugar value with the mortality rate. Now, in this graph, you can clearly say as the sugar value increases, the mortality rate proportionately increases. If the sugar is between 200 to 300, there is a 3 times high mortality rate. If the sugar goes more than 300, the mortality also becomes 4 times high. So there is a direct correlation with the sugar value and the mortality rate. Apart from clinical outcome, it can also affect inpatient complications, comorbidities, length of stay, overall hospital cost also gets increased because of diabetic complications. So the second question is, this is something interesting. Which hyperglycemia has a worst prognosis? I mean, if we have two patients, one patient is having a known case of diabetic and comes up with hyperglycemia, and the second patient is having a new onset hyperglycemia, right? So which one is having worst prognosis? And the answer is new onset hyperglycemia. The reason behind this is this pathogenesis, which we should understand. See, whenever the patient comes with the stress or underlying critical illness, then there is an increased protein breakdown. Increased protein breakdown leads to increased amino acid, increased glucose output, and there is also increased lipolysis. All of these factors lead to increased glycogenolysis, increased glucose production by the liver. There is also a lot of counter-regulatory hormones going on. There is increased steroids, increased catecholamines inside the body, inflammatory cytokines are going on. So all of these factors contribute to hyperglycemia. So I will go back to this slide. So this slide is very important. As you can see here, it was published in 2002. And here you can see the kind of hyperglycemia is correlated with mortality rate. It was a retrospective study where they analyzed medical records of more than 2,000 patients admitted in the hospital. Here you can see those patients who are having normoglycemia, mortality rate is 1.7%. Non-diabetic comes up with hyperglycemia, mortality rate is 3%. But when there is a new hyperglycemia, it is very high, it is 16%. So new onset hyperglycemia is having relatively bad prognosis, and it is the pathogenesis itself. Those patients who are having new hyperglycemia, they are badly affected by the disease itself. The sepsis or whatever the cytokine storm, whatever etiology, that is so bad that it leads to such a high level of counter-regulatory hormones, then they develop hyperglycemia. So here we come up with the recommendations for management in the hospital setting. So definitely we have OADs and insulin. OADs are generally not preferred. Insulin has been the drug of choice. So if the patient is critically ill, we will go for IV insulin infusion, and if patient is non-critically ill, we will go for basal bolus regimen, subcutaneous insulin. So first we will discuss about management of hyperglycemia in ICU setup. So insulin, it has been the standard of care. Why we use insulin? Because the pharmacodynamic of insulin allows it to be easily titrated. It is easily adaptable to the physiological change going on. Whenever we see indoor patient, there is a lot of glycemic fluctuations. So we need that kind of drug which can be easily adaptable to the physiological changes going on. Insulin, it has a rapid onset of action, minimal side effects with other drug, minimum drug-to-drug interactions. Yes, we do have a hypoglycemia which we need to take care. Has been the standard of care whenever we are dealing with the patient in ICU setup. So how we will prepare the patient is in the ICU, and how we will prepare the insulin infusion. So we use 50 units of regular human insulin to be dissolved in 50 ml of normal saline. We can give it with the help of electronic pump or infusion pump. The target sugar is, after starting the infusion, the target sugar we will keep around 140 to 180 milligram per deciliter, right? So once we start the patient on IV insulin infusion, it is always initial for the first 6 to 8 hours, we should go for hourly sugar monitoring. So every hourly we should get the sugar. When we feel that sugars are getting stable, maybe after 6 or 7 readings, we can shift to 2 hourly monitoring or maybe 3 hourly monitoring is recommended. Definitely we should check for any kind of blockage, disconnection, infusion pump malfunctioning as well. So simply start up the infusion, dissolving 50 units in 50 ml normal saline. So what should be the rate starting an insulin infusion? Initial rate of infusion, it basically depends upon what is your current sugar level. As for example, if the patient's current sugar is 200 or 300, whatever it is, divided by 100, right? So you will get, like, if it is 200 divided by 100, so 2 units per hour. Since each ml of insulin drip consists of 1 unit of insulin, so the rate is 2 ml per hour. So if it is 400 sugar divided by 100, so you will start up with 4 ml per hour. So that is the starting of insulin infusion. Once we start, then comes the question of adjusting the insulin infusion rate. So as I said, monitor capillary blood glucose hourly. Rate adjustment considers current sugar value and the previous sugar value. What is the change in the sugar value? The change in the glucose value, that is more important. And according to that, we can decide the titration. So here it is written, if there is an increase in blood glucose from prior blood glucose, we have to increase the infusion dose. If blood glucose reduction is reduced, and if the reduction is less than 30 milligrams from the prior blood glucose, still we have to increase the infusion dose because reduction is not quite adequate. If reduction is more than 30 milligram percentage from the prior value, we can continue with the same infusion, right? So yeah, here is this slide. It's a quite busy slide, but simply we have to understand the kind of fluctuation which we have. If there is an increase in blood glucose, then we have to follow the first column. If there is a reduction in blood glucose up to 30, second column. And if reduction is more than 30, the third column. And on the left side, as we can see, the blood glucose values are there. So according to the blood glucose value and the change and the shift which is going on, we can decide the rate of titration. Okay, so target is 140 to 180. If the sugars are getting down, if it is less than 90, 71 to 90, definitely we have to hold the insulin. Less than 70, Sometimes we may need to give 25% dextrose as well. But in usually we say that once we stop the insulin infusion, the sugar will again come up if you check it after half an hour. So this is a kind of a we can say protocol which we can follow in our setup for the insulin infusion titration. So there are various protocols exist like Yale protocol, Markowitz protocol, Portland protocol. All of these protocols are available on the net, and we can get the detailed protocols about this. So the question is which protocol we should follow. Basically, we do not have any head-to-head RCTs available. Like this protocol is better than the other protocol. Different institutes have their own protocol. So idea is to simply keep the sugar under control. Whatever the protocol we use, we can also individualize the treatment, but we should reach our target sugar well. So here comes the management of hyperglycemia in non-ICU setup. So two categories: sliding scale and basal bolus therapy. Definitely, sliding scale is not at all recommended. Basal bolus therapy, we can use NPH and regular insulin. NPH, if we use, we have to give it twice a day because it's intermediate acting insulin. And long acting and rapidly acting analogs, they are the most preferred technique. So there was this study that is a rabbit-2 trial. Now, in this trial, they analyzed the sliding scale with the basal bolus. It was a prospective multi-center randomized study and one of the largest randomized study. So what we can see in this slide is sliding scale, they are not able to achieve the target control. Even fourth or fifth day, still the sugar value is above 180, 200. While with the help of basal bolus regimen, we can achieve it within 2 to 3 days, our target value. So here the target glycemia was 140. With the help of basal bolus regimen, 2/3 of the patients they achieved target sugar control, while with the help of sliding scale regimen, not even 1/3 of the patients they achieved the target sugar control, and that too at 7 or 8 days. So sliding scale, the largest prospective cohort study have revealed that these sliding scale regimens, they have failed to adequately control the hyperglycemia. There are high chances of hypoglycemia as well as hyperglycemia, and they were associated with the long hospital stays. So why sliding scale is not preferred? We have very scientific reasons for this. They do not calculate the basal insulin requirement. See, many times in our residency, we used to write sliding scale 4 times sugar checking, 612, 612, and there is we are giving human extra bed, but there is no basal insulin at all. So they do not calculate the basal insulin requirement. There is a mismatch between patient's meal time and bolus insulin. We are giving the insulin at 12 o'clock while patient is not eating. So there is a total mismatch between meal time and insulin. Grossly underestimate the total insulin requirement. All patients are treated in the same manner, irrespective of etiology, irrespective of clinical conditions. So because of all these reasons, SSI regimens, they are not preferred, and you are not able to achieve the target values with the help of SSI. So basal bolus therapy has been the methodology of choice for patients who eat biscuit. It is always easy to start up with basal bolus as a separate component. Why we can keep it separate? Because we can easily titrate them. It has a lot of flexibility, and we can up titrate, down titrate rapidly as per the patient's condition and the sugar values. So basal bolus regimen, it has been the preferred. Now it is having 3 components, not the 2 components. The first is basal insulin that we will give it once a day. The second is meal or nutritional bolus insulin. Mealtime insulin, we are supposed to give it before the meal, that is before breakfast, before lunch, and before dinner. And the third is correctional or booster insulin. Now, correctional insulin is like if your post-meal sugars are not in the target range, then you give extra dose of insulin to correct that part. So that is correctional or booster insulin. We are supposed to give correctional insulin post-breakfast, post-lunch, and post-dinner. So these 3 components are needed. If we go for only 2 components like basal and bolus insulin, not the correctional insulin, still we are not able to achieve the good glycemic control. So we should always use correctional insulin. So these 3 components, they will lead to a completely. So I would like to touch upon this one point. When patient is on RT feed, So RT feeding, definitely in our clinical setup, we do come up with these patients where patient is in a non-ICU setup, patient is a bolus regimen, and patient is on RT feed. So whenever there is an RT feed, we have to, discuss about bolus part, how to give bolus. So for that purpose, we should discuss with the dietitian, divide the feed in carbohydrate and non-carbohydrate feed, give bolus insulin before each carb RT feed. So there is a formula: 1 unit of regular rapidly acting insulin is required per 10 to 15 grams of carb. So based upon this, we can calculate the insulin requirement. So as for example, if patient is on 3-hourly RT feed, so means in 24 hours, 8 times feed is required. So we can divide it like 4 times. We can give carb diet, and remaining 4 times we can give non-carb. So give the bolus insulin before each carb meal after checking the sugar. So whenever you give carb RT feed, give bolus insulin. For the rest of the times, you can skip it. So this is a kind of a practical solution when the patient is on RT feed. So pre-mix insulin, it is not at all routinely recommended, as chance of hypoglycemia in even hyperglycemia is very high. You can't properly titrate the dosages. OADs, when the patient is non-diabetic, stable patient, well-controlled HbA1c, eating regular meals, no contraindication to continuation therapy, when all of these things are fulfilled, then in those selected cases, we can continue with the OADs, but by and large, it is not preferred. So glycemic targets as per the ADA. Once insulin therapy started, a target glucose should be in the range of 140 to 180. It is recommended for majority of critically ill and non-critical ill patients. We can go for more stringent control, 110 to 140, but only in selected patients. 180 to 250 sugar acceptable in severe comorbidities with short life expectancy, but by and large 140 to 180 milligram per deciliter should be our target. There was a nice sugar study conducted, and that study revealed that more stringent sugar control is associated with a little bit high mortality. So that's why the target is always kept 140 to 180 milligram. So here comes the discharge plan: shift from IV to subcutaneous insulin. So when we should shift when the patient begins to eat and blood sugars are quite stable. Because of short half-life of IV insulin, subcutaneous basal insulin should be administered at least 1 to 2 hours prior to discontinuing the drip. Calculate the total amount of insulin needed in previous 24 hours. Whatever the insulin requirement is there, you can calculate it. Use 80% of calculated TDD for starting subcutaneous insulin. So suppose it is 30 units insulin is required, you can keep it 50% of it as basal insulin. So 15 units will be given as basal insulin, and the remaining 15 units will be given as bolus insulin, and that remaining 15 units we have to divide this according to the patient's meal. So previous 24 hours insulin requirement, first calculate that, use 80% of that, and then again divide them into 50%. Now just touch upon this part: CGM use. It is not approved by FDA for in-hospital use, as Dharmendra sir has discussed that it is not accurate in extreme glycemic fluctuations, so that's why it is not preferred. Preliminary data suggests that CGM can be beneficial, especially in COVID pandemic, where we want to minimize the contact with the patients. Many institutes have implemented the utilization of CGM because it is a bit helpful in hypoglycemia detection as well, but still more data is required. So what about glycemic variability? Now again, it's a new thing: glycemic variability in critically ill patients. More variability, it has a more negative impact and increased mortality. Better understanding of GV is required to maintain sugar under control. So we have seen that at the onset of critical illness, patients being non-responsive to intrinsic insulin, they may require higher dosage of insulin. And once the clinical condition improves, once the sepsis becomes under control, we will see that there is a significant drop in the insulin level, insulin requirement. So this glycemic variability we have to keep in mind, and we have to titrate the dosage accordingly. Illness severity, concomitant drugs, especially steroids, nutritional status, they do affect the glycemic variability as well. So we can't forget about hypoglycemia as well. So this is very important. What are the potential reasons behind hypoglycemia in the hospital? Sudden dose reduction of steroids. Now, so this is very important. Patient was on high dose of steroids, so you titrated the insulin accordingly. Suddenly, on the second or third day, when the steroids go down, we have to down titrate the insulin as well. If you don't down titrate, the hypoglycemia will take place. Emesis, decreased oral intake, bolus insulin mismatch timings with the meal. This is also quite important. Whenever there is a mismatch, hypoglycemia will take place. So the final answer is we have to individualize the treatment based upon etiology of hyperglycemia, whether it was a stress-induced, infection-induced, or if it is a steroid-induced, what kind of etiology is that? Why it is important? Because steroids, especially intermediate-acting steroids like methylprednisolone, they lead to more of a postprandial rise in the sugar. But if we are using dexamethasone, then there will be 24 hours rise in the sugar. So fasting will also be high. So depending upon the kind of steroids or whatever the etiology is, according to that, we have to finalize the plan. What is the severity of hyperglycemia? Patient is in the ICU setup or in the non-ICU setup and taking meals or not. So all of these factors we have to take into consideration rather than going for a fixed strategy. We have to individualize the treatment. So summary, when the blood sugar is more than 140, it is hyperglycemia. Get HbA1c to classify the patient. Hyperglycemia definitely affects the clinical outcome. New onset hyperglycemia, bad prognosis. Insulin remains the treatment of choice. Target sugar is 140 to 180 by and large, and we have to individualize the treatment. Thank you.
Yes, very nice talk by Dr. Meet, and very nicely elaborate and excellent talk about the in-hospital hyperglycemia management in ICU. So what's your personal experience in ICU setup regarding the...
Yes.
Yeah.
So definitely in ICU setup, the sugar variations are quite high. We have to closely monitor those patients, especially when the patient is under stress. Then the glycemic fluctuations are very high. Sometimes we need to start up. We may have to give 5 ml per hour, 6 ml per hour, 7 ml per hour. So it is possible. But when the patient improves within 1 or 2 days, gradually the insulin requirement will come down. Insulin infusion rate that will also come down, and it will take 1 or 2 days, because there is nothing like a fixed thing. You simply give the insulin and the patient will get the sugar. We have to down titrate, we have to up titrate. It is more of a trial and error. Give the insulin, see the sugar response, see how it is improving or not. So that's how things will get taken care of. But maybe within 1 or 2 days, you will get the idea. And definitely in COVID, steroids are being utilized. We do see lots of rise in postprandial sugar. So in those scenarios, we have to give a lot of bolus insulin to care of PPDS. But if the patient is on DEXA, again 24-hour sugar rise is there. So in those cases, better to use IV insulin infusion.
Okay, thank you.
Can I also
Yeah, please. Yes, please.
I have observed that in the ICU, the sugars are very commonly ignored, like because the patient has so many comorbidities. People are more, the focus is more on, say, like the patient has ICH or something. So sugars is like mostly managed by the nursing staff only, you can say. Sugar kam ho gaya, D25 de do. Sugar बढ़ गया तो insulin extra de do. Like, nobody is going to the depth of it, like क्यों बढ़ रहा है इतना, क्यों कम हो रहा है. It is I've seen it personally that
in our residency we are always using sliding scale, just writing the scale and that's it, and the sister will take care. And there is total mismatch. In the morning we are giving the insulin while the patient is not eating, so it's total mismatch. So that's why it's not going to work, definitely.
And that's why Bansi Sabu sir added RBS as a fifth vital sign, because it is very, very important.
True.
Right? Okay, Dr. Mith, thank you so much for wonderful talk. So now we have a next speaker, Dr. Tajani, my dear friend. She did MBBS from Sumandip University. She pursued advanced course in diabetology. She presented multiple papers in college. She is independently handling pediatric diabetes, gestational diabetes persons. She is interested in technologies in diabetes, distress in diabetes, and recently got a paper accepted for ATTD technology and diabetes as for the first author. So over to you, Dr. Tajani.
Thank you, Dr. Malay, for this kind introduction. I'd like to thank Vanchi sir and Vipul sir for this opportunity. I'll share my screen now.
Just click on. Click on that. Click on that. Okay. Presentation. Excellent.
Is full screen visible?
Yes. Yes. Perfect.
Good morning, everybody. My topic today for iSchool is insulin injection techniques. Today, I'll be speaking about importance of the technique, challenges faced clinically, what should be the education related to the technique, needle length, injection site, injection techniques, and safety related to the injection. As we have already known, we are celebrating 100 years of insulin, and the first insulin was given on 11th January 1922, but it was followed by a lot of complications. Insulin technique is crucial to the therapeutic success of insulin. Improper use of insulin can lead to pain, bleeding, bruising, breaking of the needle under the skin, dosage inaccuracy, poor glycemic control, and lipodystrophy. Clinically faced challenges. The first challenge what we face clinically is fear of the needle. Habit of the insulin, all the other things that we have discussed yesterday, all the clinical inertia and the patient fears. What should we educate related to the technique? Education and awareness to the patient and the caregiver plays a crucial role in enabling the efficiency of the therapy. What to educate? Choice and management of the device. All the options should be given. Syringe, pen, whatever, pump, whatever is available. Choice of injection regimen. Correct injection techniques. Factors which affect insulin absorption. Optimal needle length. Insulin site rotation, where it should be given, and how the needle should be disposed. What should be included in the prescription? What insulin you are giving, the length of the needle, the instrument with which you have to inject, the dosage, and the concentration, and the administration technique should be included in the prescription itself. Factors which affect the insulin absorption, concentration of the insulin, and the other types of insulin. The other things which can affect insulin absorption are size of the dose, physical activity, needle length, age, massaging of the site, and temperature. Needle length. In needle length, I'll be talking about the skin thickness, right space where the injection has to be administered, what are the risks related to IM injection, angle of insertion, and skin fold. Skin thickness studies were done, and averagely the skin size of all the human beings was 2 to 2.5 mm generally. So if we use a 4 to 6 mm needle, it will definitely go deeper than the skin. Right tissue space. Subcutaneous tissue is where the injection has to be done for predictable and stable absorption. If IM, then it can increase the risk of hypoglycemia as the absorption will be accelerated. Intramuscular risk, as you can appreciate from the graph on the right, it significantly increases as the size of the needle increases. The risk increases with longer needles, slim and lean patients who inject on the limbs and not on the truncal regions. This was a study done in India where it significantly shows that longer needles on the thigh and arm usage increases by 2-folds the risk of intramuscular injection. How to make a skin fold? Is skin fold really necessary? If you are giving on the correct location and the correct needle size, there is no evident data that you have to make a skin fold for subcutaneous injection. Correct way to make a skin fold? Usually, a small pinch of skin fold is made, but that is not the correct way. You have to make a thick skin fold, insert the insulin at the right angle, and then wait for 10 seconds before you pull out the plunger to release the skin fold. If you release the skin fold without releasing the plunger, it has increased chances of intramuscular injection or any other damage. Angle of insertion. Shorter needles are beneficial over longer to avoid the risk of intramuscular administration if given at 90 degrees. With shorter needles, if given at an angle or if given at 90 degrees, it will insert in the right subcutaneous area. Injection site selection. Entire abdominal region can be covered. From thighs to arms to buttocks, the rate of absorption is most at the abdomen, then at arms, then at thighs, and then at the buttocks. Wherever the subcutaneous or the fat tissue is more, insulin injection can be administered. Special consideration is pregnancy. We see a lot of patients who are very hesitant in taking truncal injections. In the first trimester, no change in the insulin technology, in insulin technique. In the second trimester, lateral parts of the abdomen can be considered, as it will not affect the fetus. And in the third trimester, lateral side and proper skin fold should be made, or thighs can be used. Insulin site rotation. We all know this is already in practice, that we have already told patients that you rotate the site. Each side should be 1 to 2 centimeters apart from the previous side. But we see a lot of lipodystrophy with patients who have to introduce insulin multiple times a day. So we have to always repeat that they have to circulate the site, they have to cover the entire abdomen, they can take it on thighs, they can take it on buttocks, they can take it on arms. And we also have to educate the patients to self-examine themselves for lipodystrophy. Changing the sites of the insulin is very important. If injected in the same spot, it can lead to lipodystrophy, as you can appreciate from the picture here. Insulin injection by a pen. We have all seen a pen. Sometimes what we face, the difficulties in that the patient plunger is stuck, the needle gets stuck. We have to tell the patient to adjust the dose correctly, tell them to fix the dose at the correct units, and then check if the insulin is coming droplet wise, and then administer it at the correct angle and the correct site. This is how it has to be done in the abdomen. Insulin injection via syringe. Syringe also, the bottle has to be inverted. It should be checked that there are no air bubbles, and then the injection should be filled and then given at the correct angle. Insulin needle reuse. Reuse is very common in India, as so many studies have shown. As in India, the principal reason patients use the needles again and again is convenience and cost. They think that we can reuse the needles. If we have set them 3 to 4 times, they will use it 4 to 5 times. Indian guidelines state clearly that awareness should be made regarding the adverse effects of needle reuse and discourage it in the practice, that needles should never be reused. Lancets are a higher risk in bloodborne pathogens like HIV and hepatitis. This was a study which showed that 92% patients using pen reused the needles and 80% of the syringe users used it. 61% Indian patients do not even remember being told that you have to use the needles only a single time. They continuously reuse it. Risk related to the needle reuse, it can lead to pain, bruising, bleeding, sterility issues, dosage can be inaccurate, and it can lead to lipodystrophy. Now coming to the last part of the techniques, it is important to educate the person about the proper disposal of the needles. You have to either burn the needles, incinerate them, and then throw it in a biohazard waste bin, which can be found either in your clinics, or you can dispose it safely using the help of a biomedical waste disposal. Thank you.
Thank you so much. Very nice talk by Dr. Tarzani. We have some. Hello, sir. Good morning. There is one question for Dr. Meet. What is the maximum infusion rate can be given in the ICU hyperglycemia patient?
It's a nice question. There is nothing like maximum dose of insulin infusion. If your sugars are not getting controlled, you have to increase it. You have to increase it by 8 ml per hour, 12 ml per hour, 15 ml per hour until the sugar gets controlled. So another practical solution for this is, suppose you have such kind of patients when you are giving 15 ml per hour, 20 ml per hour, but still sugars are not getting controlled. Then in that scenario, what we can do, we can use pure human extracted infusion. Do not dilute it, right? 50 units, make the infusion of 50 units without any normal saline dilution and then use it. So in those setups, we can simply use pure insulin, undiluted insulin, but that will be, very few cases where such a high level of insulin resistance is there, and then you require pure human extracted infusion. But there is nothing like maximum limit. You have to control the sugar. We have one case where the patient was diagnosed as having encephalitis. Because of so much sepsis and infection, sugar were not getting controlled. We titrated up to 20 ml per hour and then went shifted on pure human extracted infusion. So there is nothing like that. We have to keep the sugar under control. That's it.
Perfect answer by Dr. Meet. Dr. Dharmendra sir, there is one question for you. What is the reason for hypoglycemia after eating proper diet and dosage of insulin and monitoring?
If frankly speaking, if it's a proper diet, proper dosage of insulin, the reason of hypoglycemia can be either technique of insulin and the site where you are taking the insulin and what level of activity of you are doing. Let's say regularly a type 1 child is habituated to have a lunch of fixed and he is having X unit of insulin, but he is taking at his side. And after taking the insulin, after having the lunch, he is going for cycling. So that will increase the utilization, rapidly release that insulin, and that may end up into hypoglycemia. So of course, that activity level that might be missed sometimes, that can be one of the reason for hypoglycemia. Otherwise, if your physical activity, your food and your insulin types are matching, you must not develop hypoglycemia.
Can I have one comment?
Deepak, yes, sir.
Sometimes mismatch of syringe and vial can lead to hypoglycemia as well. 40 IU vial with 100 IU of syringe sometimes happen with that, and you tend to give 2.5 fold of higher dose of insulin, and sometimes it can also lead to hypoglycemia as well.
Yes, fine, Deepak. This reminded me one of your case. We were discussing regarding autoimmune hypoglycemia or hyperinsulinemic hypoglycemia, where that patient was having, typically postprandial after 3 to 5 hours, she will end up in hypoglycemia. Sometimes it's one of the rare disease which we called as a hyperinsulinemic hypoglycemia or Hirata disease, where
Right.
we do have antibody to insulin antibody syndrome also we call. So what happens is, a post meal that insulin antibody is having or combining with the insulin. So post meal there will be initially hyperglycemia, and afterwards suddenly releasing whole amount of insulin that will end up into postprandial hypoglycemia at 3 to 5 hours. So it is one of the rare entity of autoimmune hypoglycemia called as Hirata disease. But yeah, that may be one of the thing.
So
Good,
there
thank
can be
you.
a chance of undiagnosed underlying CKD, like this create maybe just going
Yeah,
up. And
yeah, it can be there. That's true.
Dr. Tarjani, very nice and calm talk. One comment.
Yes.
When patient taking insulin with syringe,
Yes, sir.
when he or she is taking on arm, how will you explain about skin fold?
So we'll ask the patient to make a proper skin fold so that, but if we'll not recommend it to take it on a arm if the patient is lean, first of all. We'll educate the patient that it should be taken on the truncal region where you get more subcutaneous tissue. But if they're insisting on taking the arm, if they can administer it on their own, then we'll try to explain them that a larger skin fold need to be made, and it should be taken at an angle of 45 degrees so that it reaches the correct subcutaneous tissue.
I think practically it's not possible if patient is taking with one arm, having syringe, and is taking in the other arm. So I think technically it's not possible to make
Yes,
a
sir.
skin
That's
fold
why
in that. So I think they have to take someone else help.
either they need assistance or we have to educate them correctly that it should be taken on the truncal region itself.
Right. Any of panelists having experience or their comment how they will teach?
Deepak, if you
Sir.
are, if that child is having good amount of subcutaneous tissue, then it's allowed. Otherwise, of course, as you said, it will be tough to deliver sub-Q. Patient will have to otherwise, take it at the angle 45 or less to enter the needle into subcutaneous space to get with one arm and on other arm in that way.
That's true, because this question arises. Yesterday only patient came, 8 years of type 1 diabetes, and he was 24-year-old. And when I asked where are you taking, he just told me on the lateral angle of cubital fossa. So simply he was taking in the wrong direction, because we told them you can take on arm, you can take on trunk, you can take on thighs. But practically, when I thought how we'll take on arm, then this question arises. It is not possible to make a skin fold when, particularly with the syringe. Pen, yes, size is small, needles size is small. With 45 angle you can give, but with syringe it's very difficult. So thank you so much.
So the point here, when you are prescribing a syringe, make sure that you are also writing the needle length. If
Sir.
it is 4 mm or 5 mm, which is a pen needle, which does not require any skin fold to be. If you are writing an insulin syringe, make sure that it should not be longer than 6. Tarjani nicely shown the data that how a 6 mm syringe length, the needle, not going to inside the intramuscular area in compared to a 8 mm or 9 mm or 10 mm. Still in India, we have insulin syringe which is available with 8 mm, and the skin fold is important, 45 degrees important. Otherwise, if you are using less than 4 or 5 mm, less than 6 mm, then it is mostly not required unless you are very lean or thin.
Sir.
I think
just one question I would like to have experience of all of you regarding, because what guideline has says that when we are facing up or when we are correcting steroid induced hyperglycemia or person who is on steroid, as Meet has also said that as per the different types of steroid, you will have to calculate the extra dose. Likewise, the most potent dexamethasone, it is said that 3 units per milligram of dexamethasone, you need to correct it. But it is what ideally we should start, or we can start with 1 unit per milligram and then gradually titrate, or is there any other way or any other recommendation in literature? If Dr. Meet, you can highlight it.
Actually, I don't think so. It's not in my viewpoint that whether there are any guidelines are there or not. What I remember is simply just one thing. Dexamethasone, it's longer acting. So 24 hours sugar control is required. For intermediate acting insulin, PPBS gets deranged. Yes, we do have some articles upon this, like correctional, what kind of steroids are there. And according to that, we have to, increase the insulin dosage. But it's not in my viewpoint what it exactly the value is.
Sir, my talk is on this. So from what I read, it is 0.2 IU per kg we'll have to start, long acting. And then according to the fasting sugars, we'll have to up titrate and down titrate it.
But what type of steroid we are using, and based on that, what dose you will choose. Because if you are going to use prednisolone, of course, it will be 0.45 unit per milligram of prednisolone extra insulin you need to give to correct that steroid-induced hyperglycemia.
Yes.
The same way, what I am saying is, dexamethasone, it is said 3 unit per milligram of dexamethasone you need to start. Now, if you see in ICU setting, sometimes 4 milligram, 8 hourly dexamethasone neurosurgeons will be giving to their post-op patient even. So if we calculate, it is 12 milligram of dexamethasone daily going on minimum. So 12 into 3, it is 36 extra unit of insulin we need to deliver. So practically sometimes, ICU people and other people will have fear in mind. So in that way, just we need to come up and we need to start up with 1 unit per kg and then gradually go as per the patient response. So that's what I was asking, whether we do have such any literature or any other guidelines are there or not. That was I was just inquiring or looking for.
Pertaining to literature, Dr. Dharmendra, nobody knows better than you. So I think if you don't know,
yes, steroid master.
So always in terms of literature, we ask you, so what is the new literature, what is new guideline, what is new statement about molecular or anything. So it's up to you. You have to find out now for us. Thank you.
We have our own data and we will work on that only.
Yes. I think with this, we can end our discussion for this session and we can move on to insulin in special situation, our next session. And for that, our first speaker is Dr. Ruth Goklani, sir. I'll introduce him. I think Dr. Akash can do that now. Has he joined?
Dr. Akash?
Yes. Okay, I'll do it. Can you please put the next slide? Dr. Ritul is MD, diabetologist and fellow in diabetes from Liverpool, UK. He's a postgraduate diploma in diabetes, complications and technology. He is certified in diabetology from RSSDI. He's also done CCMTD, CCGDM, CCDR and CCEBDM. He's a consultant diabetologist at AHC Diacare Clinic and is also associate consultant at Diacare Syringe, Ahmedabad. He's a member of RSSDI, ESG, AD and ISPAD. He has special interest in diabetes and infertility, gestational diabetes and type 1 diabetes and obesity. Over to you, sir.
Thank you very much, Dr. Kumudi. Am I audible properly?
Yes, audible and visible. Very nice looking.
Okay, thank you. And you may have some of the disturbance in voice, maybe background voice could be there because I am at a very remote place and at my village place. So maybe My slides are visible, right?
Yes, sir, visible.
Yes, please continue.
Thank you. Thank you. So my today's topic is about perioperative management in diabetes. So for introduction, thank you very much, first of all, Bansi Sabu sir and iSchool Diacare team, Vipul Bhai, for having me here and giving me the chance to talk on such a wonderful topic that is really very important and very close to my heart, because what the reference we get throughout our practice, when the patient is too much uncontrolled, or the physicians or the doctors who are taking care of their insulin treatment, they are unable to make the patient's blood glucose control properly, then only they send the patient to us. Or sometimes the patient themselves, they come up with the problems only, like sir, અમારે તો આંખનો એટલે અમારે મોતિયો ઉતરાવવાનો છે, ઓપરેશન કરાવવાનું છે, એટલે હવે તમે અમારું શુગર કંટ્રોલ કરી આપો જેથી અમારી સર્જરી થઈ શકે. So it is very common scenario in routine practice. For that, I will introduce that management of glycemic levels in perioperative settings is really critical, especially in diabetic patients. And we know that it is 1+1 is always not 2 in perioperative cases. You may speculate something in different cases, like in routine OPD, but we never know how the patient will behave in our perioperative settings. The effects of surgical stress is very much different in each patient, and anesthesia has unique effects on blood glucose levels. So each stage of surgery presents unique challenges in keeping blood glucose within target range. So when we want to keep it strictly between 140 to 180, it is quite a challenging thing. Additionally, there are special operative conditions that require distinctive glucose management protocols. Every ICU setting has their different protocol they follow. Every hospital has different protocol. Some of the hospitals, they do not follow any kind of protocol at all, and they just simply follow the sliding scale. So why is management of diabetes important in surgical settings? We know that surgical procedures may result in number of metabolic perturbation that can alter normal glucose homeostasis. So we know that whenever the patient come up with the infection or any kind of that stress situation, and in such stress situation, definitely blood glucose control is very bad. So resulting hyperglycemia due to abnormal glucose balance is a risk factor. And that risk factor are for post-operative sepsis, for endothelial dysfunction, cerebral ischemia, and impaired wound healing. So definitely, when the blood glucose control is not good, the surgical procedure is also at risk. And if surgical procedure has been done good, then the wound healing is also very important part when it comes to blood sugar control. Stress response may also cause other diabetic pathologies, that is diabetic ketoacidosis and hyperosmolar syndrome, that is hyperglycemic hyperosmolar syndrome during surgery or maybe post-operatively. But most commonly we see is diabetic ketoacidosis, but very often we see HHS, because nowadays no patient is left alone, and no patient is left alone at home and dehydrated. It is a very uncommon condition nowadays. Recent evidence suggests that careful management of glucose levels in patients undergoing major surgeries may minimize the negative sequelae and overall promote better outcomes. So it all depends on perioperative management of blood sugar, which takes place in outcome of the surgery. So what really started the discussion when we have intensive insulin therapy in critically ill patient, the New England Journal of Medicine has in 2001, way back before 20 years, we came to know that improved outcomes with glycemic control in a hospitalized patient, whether it is survival in ICU or in hospital survival. Definitely, Vipul bhai, please mute yourself. Vipul bhai. So improved outcomes in glycemic control in hospitalized patient, whether it is survival in ICU or in hospital survival, both makes around 40% of reduction if we do the intensive control. So intensive control makes a very big difference for survival as well as in hospital survival. So the success of the DGAMI study, Portland study, and Vandenberg study that I talked before, one slide was the Vandenberg study, which was conducted in 2001. This Vandenberg study did a confirmatory study, and it carried out on in medical ICUs. So after that, we came to understand the importance of intensive control. What NICE sugar study in 2009 told us that when we keep intensive control, that is around 120 milligram per deciliter, and in conventional glucose control, when we try to keep it less than 160 or 180, what are the differences? What difference it makes in blood sugar control and outcome of the patient. So by that only guidelines were made that what should be the ideal blood sugar control. So NICE sugar study that has findings that were amplified by the results of NICE sugar study comparing ICU patients on intensive glucose control with a target blood glucose range from 81 to 108. That was quite a strict blood glucose control to those on conventional glucose control with 180 mg or less per deciliter. After 90 days of follow-up of 829 patients, there was 27.5% in intensive control group and 751, that was around 25% in conventional control group, had died. So this unfavorable outcome did not differ between surgical and non-surgical cases as well. So what we found out that definitely we have to keep it between 100 to 180. This is what this NICE sugar study explained. Perioperative assessment and management goals for the diabetic patient were broad management goals across the perioperative timeline, where reduction of overall patient morbidity and mortalities and avoidance of severe hyperglycemia or severe hypoglycemia. The important thing is hypoglycemia also there. So maintenance of physiological electrolyte and fluid balance is important, as well as prevention of ketoacidosis. So establishment of certain glycemic target levels less than 180 in critical patient and less than 140 in stable patient is advisable. Pre-operative management key points were verified: target blood glucose concentration with frequent glucose monitoring, use insulin therapy to maintain glucose goal. Definitely all other oral hypoglycemic agents can be used in a very stable patient, but and in minor surgeries, but insulin therapy is always advisable and encouraged. So discontinue bigunides, especially metformin, alpha glucosidase inhibitors or pioglitazone, especially sulfonylurea and GLP-1 receptor agonist. Also, they have not mentioned here, but SGLT2 inhibitors are also supposed to be stopped. Consider cancelling non-emergency procedure if patient presenting with metabolic abnormalities like DK or HHS or glucose readings are above 400 or 500 milligram per deciliter. So intraoperative management key points, we aim to keep it between 140 to 170. Here it is written, but we ideally we should keep it between 140 to 180, and it should be in written form whenever we are going to see a patient during intraoperative management. So physicians must take a length of surgery into account when determining the intraoperative glucose management strategy. For minor surgeries, definitely pre-operative glucose protocols may be continued, but IV infusion is being promoted as a more efficient method of glycemic control for longer and more complex surgeries. For smaller surgeries, definitely we can use basal bolus and our scales that we write usually before and after meal, or the way we usually practice. But for longer and complex surgeries, IV infusion is encouraged. So post-operative management keys, where target post-operative glycemic control should be between 140 to 180, and in the event patient is hypoglycemic after surgery, then begin dextrose infusion at approximately 5 to 10 gram per hour. And sometimes we need to give the potassium as well if the patient is having hypoglycemia. Sometimes we have to give dextrose, potassium and insulin drip in some of the patient after the patient comes back into normal blood glucose control. Ensure basal insulin levels are met, and especially in type 1 diabetic patients. So never stop basal insulin, especially in type 1 diabetic patient, at least smaller doses of basal insulin, which prevents diabetic ketoacidosis like conditions. So basal insulin should be given not possible in full dose if patient blood glucose are sometimes on hypoglycemic range, then we may give it in smaller doses. Postprandial insulin requirement should be tailored according to the mode in which the patient is receiving nutrition. Also, supplemental insulin can be used to combat hyperglycemia in between and to restore blood glucose values back to target range. Even if we are following basal bolus regimen where we check blood sugar 6 times, and if post-meal blood sugars are high post-operative management or the situation, then we may definitely give extra shot of insulin in such patients where their blood glucose control is very uncertain. So management in special circumstances where minor procedures, pre-procedure glycemic control, glycemic management in regard to the timing of the surgery, insulin regimens for hyperglycemia management in post-op period, and evaluation for emergency surgery. Minor procedures like cataract or dental procedures or some minor DNC, where all procedures do not require patient to be in hospital overnight and are anticipated to miss not more than one meal, are considered minor procedure, and some therapeutic or diagnostic procedure requiring overnight fasting for more than 8 to 10 hours. So target for therapy are categorized as pre, intra and post procedures, where pre-procedure glycemic control, ideal glycemic control for fasting is between 80 to 120, but if it is less than 140, then it is acceptable. But if it is more than 140 of fasting blood glucose control, then we should intensify our treatment. Postprandial blood sugar should be less than 160, but if it is less than 180, then it is acceptable. But if it is more than 200, then we should intervene. And HbA1c is should be between 7 to 8%, but for intensification, we should intensify the treatment if HbA1c is more than 9%. Glycemic management in regard to the timing of the surgery. For monitoring morning procedures, on the day prior to procedure, patients should be advised to take full dose of anti-diabetic medicines, including insulin, especially basal insulin. And OADs at the dinner. The patient will remain nil by mouth till procedure is complete in the morning, and patients should take their usual dose of insulin or OADs when they have breakfast by mid-morning. If procedure is delayed unexpectedly and the blood glucose levels are above the target, like more than 180, then insulin infusion should be started. If the facility of infusion is not available, subcutaneous correction dose or short-acting insulin may be given, but we can give it without infusion if you know the correct method through the dial flow meter. So the acting insulin may be given followed by close monitoring to avoid hypoglycemia. For patients who are not on insulin or on OADs or GLP-1 receptor, all oral hypoglycemic agents and GLP-1 receptor agonists can be continued as usual on the day prior to procedure, but should be omitted on the morning of the procedure. Oral hypoglycemic agents and GLP-1 receptor agonists should be resumed once the patient resumes their diet and not before that. Some of the patients are given tablets during the trials, tube feeding and all, and it should not be advised. Metformin may not be discontinued for minor procedure unless there is renal, cardiac or hepatic impairment. So metformin can be continued in minor procedure or minor surgeries. For procedures requiring intravenous radiocontrast administration, it is recommended to discontinue metformin 24 hours prior to the procedure. And usually in our country, it is not common practice that before any radiocontrast administration, we do not stop this metformin. And this is actually, it should be come into practice when we are learning about insulin and other things today and perioperative management. Metformin can be restarted after confirming normal renal function after 48 hours. So it should not be immediately started, but it should be started after 48 hours after seeing their renal function test. For patients who are not on insulin or oral hypoglycemic agents or GLP-1 receptor agonists, patients with long duration type 2 diabetes, those receiving more than 2 oral hypoglycemic agents, likely to deteriorate after discontinuation of anti-diabetes medication. So similarly, dysglycemia is more likely in patients with poor pre-procedural glycemic control, and if procedure is unexpectedly prolonged or complicated. So why it is important to keep the blood glucose control in the level? Because the patient who are priorly not controlled, they are going to have more complications. So this patient should be treated with insulin infusion during procedure and may require subcutaneous insulin for short duration after procedure as well. So what guidelines for perioperative adjustment of insulin they explain? Basal insulin once daily when the patient is taking in the evening. So day prior to admission, no need to change the dose. On the morning surgery, no dose change is advisable, and check blood glucose every 6 hourly. Afternoon surgery, if there is afternoon surgery, then even no dose change is required, and check blood glucose 6 hourly. So if patient is taking only basal insulin, then we do not need to do any kind of routine changes, but every 6 hourly at least we need to check the blood glucose levels. If patient is taking once daily basal insulin in the morning, then again the procedure should be same a day prior to admission, day of the surgery, whether it is morning surgery or afternoon surgery. If patient is taking twice daily premix insulin, day prior to surgery, we do not need to change anything, but on the day of the surgery, if morning surgery, then half the usual dose of morning dose, and check blood glucose 6 hourly. Leave evening dose unchanged. In the evening, we don't need to change the dose, but we need to check the blood sugar. If patient is having hypoglycemia or patient is having blood glucose level on lower side, then we may reduce the dose of evening insulin in premix. Afternoon, if there is afternoon surgery, then morning dose should be usual, but evening dose should be according to blood glucose levels, and it may be reduced, or sometimes we may need to increase the dose of premix insulin. If patient is taking twice daily separate short and intermediate acting insulin, which is usually common in type 1 patient, but not in our type 2 patients. So for day prior to admission, no need to change the surgery. For on the morning day of the surgery, calculate total dose, both morning insulins, and give half as intermediate acting only in the morning. So check blood sugar again 6 hourly, and leave evening dose unchanged. Supplement correction dose if short acting insulin as required. And it is same as for afternoon surgery, just we need to shuffle the timings. If patient is taking basal bolus regimen or 3, 4, or 5 injections daily, then on day prior to admission, we don't need to change the dose. Sometimes we need to increase the dose if patient is uncontrolled, but basal bolus insulin, we should omit the morning dose if there is morning surgery. Lunchtime short-acting insulin can be given if the surgery is not too long. Keep the basal unchanged based on blood glucose values. For premix, morning insulin, half the morning dose, and omit lunchtime dose, and like we explained in twice daily. For afternoon surgery also, there is a same kind of thing, but we need to shuffle the timings. So guidelines for perioperative adjustment of non-insulin medication. Day prior to admission, acarbose can be taken normally. For morning surgery, omit morning dose of needle by mouth. And afternoon surgeries, give morning dose but not evening dose. For meglitinide, day prior to surgery, same dose can be taken, whether it is metformin, sulfonylurea, DPP-4, or GLP-1 receptor agonist. We may accept GLP-1 receptor agonist. All medication can be taken day prior to admission. But if there is morning surgery, then we take metformin as a normal dose. Sulfonylurea, we should omit morning dose if there is morning surgery. And for twice daily patient, omit or please do not give morning dose. For DPP-4 inhibitors, omit the morning surgery. If morning surgery, then omit the dose. And for GLP-1, it is also the same. And for afternoon surgery, what we need to do, that morning dose should be same, but for sulfonylurea, when there is only once daily dose, then we are not going to give morning dose even if the surgery is in the afternoon. So insulin regimens for hyperglycemia management in post-operative period, where immediate post-op period, IV insulin protocol should be followed. For enteral feeding, basal plus bolus with correction bolus should be given. For Riles tube feeding, low dose basal with short acting insulin every 6 hourly, rapid acting insulin every 4 hourly as correction bolus, or NPH with short acting regular insulin every 8 hours or 12 hours. For parenteral nutrition, add 0.1 unit regular insulin per gram of dextrose in non-diabetic patient, but for diabetic patient, we need to increase a dose a little bit, where 0.15 unit of regular insulin per gram of dextrose in diabetic patients to parenteral solution as IV infusion or basal with short acting insulin every 6 hourly if blood glucose is more than 180. Now the evaluation for emergency surgery. This is very important point where the patient is coming in emergency condition, where we need to assess them properly, whether it is metabolic status for measurement of plasma blood glucose, their pH, urea, creatinine, and electrolytes with urinary ketones. Also, we need to assess their volume status properly, check for the orthostatic hypotension, elevated BUN or creatinine, urine output, osmolality, adequacy of peripheral circulation, and also cardiorespiratory status always need to be thoroughly evaluated, where ECG, chest X-ray, and 2D echo should be done with delayed surgery if possible until metabolic control and volume status are stabilized. Also, optimize blood glucose and electrolyte with acid-base status. With this, I will conclude that clinical judgment must still be used to assess specific changes, even though number of protocols are available. Healthcare professionals should remember that glucose homeostasis during perioperative period is extremely variable. Blood glucose levels as well as electrolytes and acid-base status should be carefully monitored, and healthcare professionals should be mindful of patients' normal diabetic regimen, where after making all necessary changes during perioperative period, aid the patient's transition back to normal glycemic management protocol through careful perioperative glucose management. Surgical complication as well as hyper or hypoglycemia sequence may be reduced and improve patient morbidity and mortality. With this, I would like to thank everyone for patient listening. And if we have any question, we may go right now, as I have to leave, as I'm leaving. I have to go somewhere else. So please.
First of all, special thanks to Dr. Rutul sir. As usual, wonderful and excellent talk about the perioperative management in type 2 diabetes mellitus patients. We have Dr. Deepak, Dr. Dharmendra, Dr. Tom Moody, but there is no any question for you, Dr. Rutul. So thank you so much.
Sir, that was really a very good talk. You covered every aspect of pre and post operative sugar monitoring, and that too in very depth.
Oh, thank you. And I would take a leave now. Sorry, I have to go.
Yes, please.
Okay.
Yes,
goodbye. Thank you very much again. Goodbye.
So now we have another speaker, young dynamic diabetologist from Ahmedabad, Dr. Tom Moody, and she has wonderful topic: glucocorticoids and chemoradiotherapy. So just slides.
Ankit bhai, next slide karo.
Yeah. So she did MBBS and MD General Medicine. She is currently pursuing advanced certification course in diabetes. She presented papers and publication in state and national conference during post-graduation. And area of interest include technology in diabetes, GDM, and diabetes. Over to you.
Thank you, Dr. Malay. I'll share my screen. Are my slides visible?
Yes, visible. Yes.
Thank you, Malay. To begin with, I would like to first thank Dr. Banshi sir, Dr. Vipul sir, and the whole organizing team for giving me this chance to speak on this topic. The topic for today is insulin special situations, glucocorticoids, and chemoradiotherapy. Just a moment. I'm a full screen a bit. Okay. Sorry, I'm not able to increase the size beyond this. I'll continue from here. As we know, the use of glucocorticoids have increased a lot in the recent past, and this becomes a very relevant topic to talk about. It's a major common challenge faced by clinicians due to increasing usage of steroids across all specialties. Diabetes mellitus incidence in patients without a prior history of hyperglycemia to steroid use varies from 34.3 to 56%. It increases the risk of infection, HSS, hospitalization, prolonged hospital stay, DKA, and whole other complications. So it becomes very important to manage SIH effectively. To begin with, I would like to talk a little bit of, give a brief introduction of corticosteroids. They are synthetic analogs of the natural steroid hormone produced by the adrenal cortex. They include both glucocorticoids and mineralocorticoids, while mineralocorticoids regulate electrolytes and water balance. The term glucocorticoids, in practice, we generally refer to glucocorticoids. Glucocorticoids are potent anti-inflammatory and immunosuppressive drugs, and we classify them in short-acting, intermediate-acting, and long-acting. This is important to know from diabetes point of view because the type of insulin that we would use would depend on the duration of action of the glucocorticoid that we would be using. There are, like I already mentioned before, there are a whole wide of indications for use of glucocorticoids across all specialties, right? They are used by pulmonologists, right from asthma, COPD. They are used by dermatologists in contact dermatitis, pemphigus vulgaris. They are used in long term by rheumatologists, ophthalmologists, and obviously in patients who undergo organ transplant, and the most recent one, that is patients of COVID-19. The steroid-induced hyperglycemia can be divided into three types. First is newly detected hyperglycemia in previously normal glycemic patient. Second is newly detected hyperglycemia in previously undiagnosed diabetes mellitus. And third is worsened hypoglycemia in known case of diabetes mellitus. These are the risk factors for glucocorticoid induced diabetes mellitus. Not everybody who is put on glucocorticoid may develop diabetes immediately. Some have more risk. These are the ones who are at more risk. Those who are put on high doses of glucocorticoids are defined as those on prednisolone more than 20 mg, hydrocortisone more than 50, and dexamethasone more than 4 mg. Those who are on longer duration of glucocorticoid treatment, those with advanced age, those who are obese, those who have previous glucose intolerance or impaired glucose tolerance, patients with personal history of gestational diabetes or previous glucocorticoid induced hyperglycemia, family history of diabetes, and those who are pre-diabetic. To talk briefly regarding the pathophysiology of corticosteroid-induced hyperglycemia, corticosteroids work at multiple levels to cause hyperglycemia. They work right from increasing insulin resistance, that is, they decrease the uptake of insulin, they decrease the uptake of glucose in the skeletal muscles. They also decrease the production of insulin from the pancreatic beta cells. They also increase the glucose production from the liver. So basically at every point, at every level, corticosteroids work to cause hyperglycemia. I'll reshare my screen, I think. Can everybody see my slides? Dr. Malla, can you see my slides?
Yes. Yes, please continue. Yes.
Yes. To talk more in depth regarding insulin resistance, it has been observed that the patients on glucocorticoids mainly develop postprandial hyperglycemia. Intermediate acting glucocorticoids have peak of action 4 to 6 hours following administration, causing hyperglycemia mostly after meals, and the FBS may be normal in these patients. And but at the same time, they can cause persistent hyperglycemia if given in divided doses. Long-acting glucocorticoids can cause hyperglycemia that lasts for more than 24 hours with a slight decline over an overnight fast. How do we label a person that the person is having steroid-induced hyperglycemia? The parameters remain the same, that 8-hour fasting glucose should be more than 126, or 2-hour post 75 gram OGTT should be more than 200, HbA1c more than or equal to 6.5, or RBS more than 200 with symptoms of hyperglycemia. But like I already mentioned, in cases of intermediate glucocorticoid, patients taking intermediate glucocorticoid steroids, the FBS may be normal. In these cases, postprandial glycemia offers the greatest diagnostic sensitivity. So when these patients are on steroids, we should particularly tell them to monitor their post-meal glucose along with their FBS. We commonly see that people just keep measuring their fasting blood glucose. Bhuke pet ka map liya, but खाने के बाद का they miss out a lot of time. So that is what we need to take care when we are seeing patients on steroids. Non-diabetics, and there's a recommendation that non-diabetics on oral steroids should be screened once to twice weekly, 2 hours post-lunch. It has also been reported that 50% of the time glucocorticoid-induced diabetes occurs between the 2nd and 4th week. Coming to the management of SIH in clinical practice, like management of like the basic going to the basics of management of diabetes, we have to go to lifestyle modification. In OPD settings, when patients are on oral steroids, OHAs are a good option, and if the patients are already on OHAs, then we need to optimize the doses of OHAs. But then OHAs have their own limitations when we are treating steroid-induced hyperglycemia, because OHAs because steroid-induced hyperglycemia causes transient hyperglycemia, and OHAs take a little time to exert their full action. So that it may not be exactly suitable to use OHAs, but if they're already on, we can always try to maximize the doses. Plus, OHAs from different groups have their own limitations when we are giving them to patients on steroids, because like pioglitazone and metformin.
Sorry to interrupt. I think slides are not moving.
Yes, slide is not moving right now.
Just a minute.
Yes, now it's moving.
Okay. So is the slide management of SIH in clinical practice? Because
Yes.
So like I was talking, these drugs have their own limitations. Like say pioglitazone and metformin, they are insulins. They increase the insulin sensitivities, so patients can be put on these. But then patients who are already on glucocorticoids may have other pre-existing comorbidities like renal dysfunction, or acid. They pH may be a little on the lower side, so metformin may be contraindicated in these patients. And pioglitazone, if you say so, it increases the risk of bone fractures, and steroids themselves have osteopenic effects, so that also poses a problem. Coming to discussion on sulfonylureas are good options, but because we have transient hyperglycemia with steroids, there is a higher risk of hypoglycemia. Sulfonylureas, as such, we know they pose a risk of hypoglycemia, and when added to a very brief period of hyperglycemia, it may not be exactly very suitable. Plus, steroids are always given in tapering doses, so it becomes very difficult to taper the doses and adjust the doses of OHs and titrate the doses. In patients who are hospitalized, Then clinically, many trials have shown that OHS have very little role to play. In these patients, the only answer is those who are hospitalized and on IV insulin, the only answer is insulin. In general, in hospital patients who are already diabetic with uncontrolled sugars, they should be started on basal bolus therapy. And those patients who are newly diagnosed with fairly controlled sugars, they can be put on bolus doses only. Coming to why insulin over OHS, the action profile of OHA drugs without of oral hypoglycemic drug throughout the day does not usually coincide with the pattern of glucocorticoid induced hyperglycemia. They have a rapid response. Their dose response is predictable. We always have the flexibility to titrate the doses. And there are multiple insulin options for different type of steroids. Like I spoke before, we have different type of steroid according to the duration of action. So multiple insulin options also according to their duration of action. And unlimited hypoglycemic power and can be easily titrated. Like Dr. Mead said, that if the patient is having uncontrolled sugars, we can very high sugars, we can always put them on IV insulin. And so this is what it is, like unlimited hypoglycemic power. I would now discuss the different regimens. This I've written from an article that was published in Journal of Clinical Medicine in 2021. So these are the latest guidelines available. So first scenario would be short-acting glucocorticoids. The example would be hydrocortisone. So when like from this that you can see their duration of action is around 6 hours. So if they're given in the morning at 8 o'clock, you can see that their effect would wean off by 2 o'clock, 3 o'clock in the afternoon. So we need to be giving them insulin that works for only this much time. So the best choice would be to give a short-acting insulin. They can be either given right when the glucocorticoid is administered, or shortly after that, depending on the duration of the action of insulin. If the glucocorticoid is given multiple times, we can even increase the dose of we can give multiple shots of short-acting insulin. The initiation dose is around at 0.1 unit per kg. And if the preprandial sugars, the sugars obviously need to be monitored. And if the preprandial sugars are between 200 to 300, then along with 0.1 international unit per kg, there has to be an additional correction dose given of 0.04 international unit per kg. And if the preprandial sugars are more than 300, we would like to increase the dose even further by 0.08 international unit per kg respectively. So this was scenario 1. In scenario 2, when we are scenario 2, we'll talk about patients on intermediate acting glucocorticoids, that is prednisolone. These are the most commonly used in our routine practices that we see. Their duration of action is around 12 to 16 hours. Sometimes they are also given in 2 doses. So as you can see, like almost 24 hours, the patient is in a state of hypoglycemia with 2 major peaks. According to guidelines, you should be using an intermediate acting insulin like NPH or Detimar with an initiation dose of 0.5 international unit per kg. There were 2 RCTs that were conducted, and they found that insulin glargine is non-inferior to NPH in these patients, and they do not even cause a very significant hypoglycemia at night. So glargine can also be used in these patients. If needed, if multiple doses of glucocorticoids are given, then NPH can be given twice daily. And if necessary, additional bolus doses of rapid acting insulin can also be given according to their preprandial sugar levels. Yeah, prednisolone, they've also given in the recommendation that if the prednisolone is started at more than 40 mg dose, then the initiation dose should be 0.4 international unit per kg, at 30, 0.3, 20, 0.2, and 10, 0.1. So this is roughly with this idea, we can begin our insulin initiation. The third scenario is when the patient is put on long-acting glucocorticoid like dexamethasone. As it is seen, the action would stay for 24 hours. Even it can stay up till even 36 hours. The best option for these patients would to put them on long-acting insulin like Glargine at 100 units, or even the 300 unit one like Tresiba, or we can even put them on Degludec. The initial dose should be at 0.2 international unit per kg. Alternatively, they even have given a choice of NPH that can be started. But NPH would be divided into 2 doses because it is intermediate acting. So it would be started at 0.3 international unit per kg with 2/3 dose in the morning and 1/3 dose in the evening. But practically speaking, the long acting like Glargine would be a better option. Then the titration is guidelines say that if the glucose levels go below the fasting glucose level go below 70, then the insulin dosage should be decreased by 20%, and if it is between 70 to 110, then the titration should be by 10%. Similarly, if the glucose level values increase more than 320, then increase the dose by 20%, and if it goes between 220 to 320, increase it by 10% only. And according to the preprandial sugars, we can add additional boluses of rapid acting insulin. And for patients who are already on insulin, the dose should be increased by 20%. And after that, the percentage of insulin adjustment corresponds to half the percentage of in steroid change. Example, if steroid dose is reduced or increased by 50%, insulin dose will be reduced or increased by 25% respectively. If high doses of steroid are given, insulin dose can be even initiated at 0.7 international unit per kg per day. And in hospitalized patients receiving high doses with the glucose above 400, they can be put on insulin infusion pump, like as we saw in patients of COVID-19. Coming to hyperglycemia and chemoradiotherapy, these patients of chemoradiotherapy are generally put on corticosteroids, and they are obviously under a lot of stress, which causes hyperglycemia in these patients. The combination of chemotherapy, corticosteroid stress puts patients at risk for developing hyperglycemia, which affects chemotherapy dose reduction, interruptions, or stoppages. Poor glycemic control in cancer patient is associated with the more clinically aggressive cancer course, and it also increases the chances of infections, neutropenia, and also mortality. Generally, chemotherapy is given intermittently, like 3 to 4 days in a month, and the next cycle would come the next month. So these patients are put on steroids for these patients are put on insulin only for these days with very intensive sugar monitoring. And the grill remains the same, that because patients of chemotherapy develop hyperglycemia mainly because of steroids, what I discussed before, the same thing applies regarding the management. There is another aspect to patients, cancer patients, that is that these patients may be on tube feeding or may be on total parenteral nutrition, because those patients who say have esophageal cancer or oral cancers or have undergone some major surgery of colon cancer or something, so they are put on total parenteral nutrition. So in these patients, regular insulin is added to the TPN solution to keep a control of blood glucose. Initial doses are 1 unit per 10 grams of carbohydrates, and the dose should be titrated daily until glycemic control is attained. Alternatively, NPH twice daily, Guardian once daily can also be used. Dr. Deepak will talk about this more. This is his topic. He'll be speaking after me. So with this, I would like to end this talk. Thank you.
Thank you so much, Dr. Pramodi. Though very tough topic, but you elaborate very nicely and calmly and in depth. So one question for you. What is the reason of ketoacidosis after HbA1c is 7 to 8?
HbA1c of 7 to 8 and the patient is having keto. This can happen in patients of type 1. I mean, this is not related to my topic, I guess, but this can happen in patients of type 1 who may be having a good glycemic control otherwise in the last 3 months, but they might have missed their recent doses of insulin, and that can cause hyperglycemia, and as we know that lack of insulin will cause ketosis in these patients. This can happen in type 1 also, and in patients with severe, even in adult patients with severe insulin deficiency. Recently only we had a patient.
Because there is one of the reason is once the sugar is higher side, there is absolute insulin deficiency and relative insulin deficiency, and by that time there is an increase in the counter regulatory hormones. So there is an increase in the lipolysis, decrease in the protein synthesis, proteolysis, and there is an increase in the free fatty acid. So there is a ketogenesis occur, and there is a ketoacidosis occur. And once the hyperglycemia, that lead to the glycosuria. So that lead to the loss of water and electrolytes. So ultimately there is a dehydration and there is a depletion of the electrolytes, and ultimately lead to the impaired in the renal function, and there is a decay. So once the HbA1c higher side, there is a risk of the ketoacidosis.
But that question particularly was that with the fairly controlled HbA1c, why is this patient going into decay? That could be one reason, that they missed their recent dose of insulin, like that in the recent 2 to 3 days. If they've missed their doses, so they can obviously develop decay. And you already explained the pathogenesis of it.
So another question is night tablet of glycomet SR 500 milligram is causing diarrhea. If not taken, fasting sugar is higher, almost 130. So what is your suggestion to the patient age 64 years?
What is night tablet of
I think it's not related to your topics, but is a general question for all of us. Night tablet of metformin 500 milligram sustained release is causing diarrhea. If not taken, fasting sugar is almost 130. So what is your suggestion to patient age almost 64 years?
There are so many other groups of drug we can try. We can go for SGLT2.
Yes.
Because to answer this.
Yeah, there's a very once we have to check the kidney levels, creatinine, and if there is CKD or not, cardiac history present or not, obesity or not, any comorbidities or not. And according to all AD and ESTD guidelines, irrespective of HbA1c, if the patient has the CKD or heart failure or established cardiovascular disease, you can use the SGLT2 inhibitors or GLP-1 receptor agonists with CV benefit. Or if you want to avoid the hypoglycemia, you can use the DPP-4 inhibitors. And if you want to weight loss, you can use the SGLT2 inhibitors or GLP-1 receptor agonists. And for that, we have RSSDI guideline also.
Yeah, because we have so many groups that can be tried in this patient, like apart from metformin.
So, thank you so much, Dr. Pramodi, for wonderful talk. Thank you.
I think we can move on to our the next. I think Dr. Malay is going to be speaking on peripartum and GDM. I'll introduce him. Dr. Malay has done MBBS, DNB, and MNAMS and PG CDM from UK. He has done fellowship in diabetes from UK and also ACCD from RSSDI. He's a postgraduate diploma in diabetes from UK. He's a consultant diabetologist at Rajkot. at Lalit Alay Rotary Midterm Diabetes Prevention and Lifestyle Management Center, Rajkot. He's a member of RSSGI, ADI, ISPAD, ESD, ACP, IMA. He has submitted many research abstract papers, selected and presented in many national and international conferences and published in various journals. He's been invited to many conferences as a speaker, faculty, organizing committee member, scientific coordinator, panelist, and chairperson. He's an investigator in many clinical trials. He's also a treasurer of RSSGI Gujarat chapter. So Malay, over to you.
Thank you so much, Kaumudi, for nice introduction. And first of all, special thanks to my mentor, Dr. Bansi Sabu sir, and my dear friend, Dr. Vipul, for giving me this wonderful opportunity. And also special thanks to some of you who organized wonderful school, 100 year of insulin, for very nice introduction of the use of the insulin in various conditions. So now I am going to share my screen. And my topic is very, very important because peripartum and GDM. Is it visible?
Yes, Dr. Malay, it's visible.
Okay, so thank you so much for confirmation. Now I am going to start my share. Today I am going to speak about the management of the diabetes in special conditions like peripartum and GDM patients. So why is this important? Because we all know peripartum control of diabetes is very important because high incidence of the neonatal hypoglycemia is seen if maternal hyperglycemia happens during the period. And the most important aspect of the peripartum management of diabetes is to avoid the maternal hyperglycemia. And maternal hyperglycemia increase the chance of the neonatal hypoglycemia and fetal acidemia. Another tight glycemic control is necessary for women with pre-gestational or GDM throughout the pregnancy, and it is more crucial during the labor. And monitoring of blood sugars along with the continuous glucose infusion for the peripartum management of the diabetes lead to less hypoglycemia and fewer incidents of the side effects. So insulin requirement in intrapartum period, it's depend on the type of the diabetes, because women with type 2 diabetes and GDM have adequate endogenous insulin production, and women with type 1 diabetes have almost to no endogenous insulin production. Second factor is the phase of the labor. During latent phase, the requirement of the insulin is stable, but active phase, insulin requirement comes down markedly, especially in the patient with type 2 and GDM patients. And the third factor is control of the sugar during the pregnancy also has bearing on the requirement of the insulin during peripartum period, because women with previously uncontrolled sugar require high dose of the insulin, and women with wild requirement very low in the women with good control the sugar during the pregnancy. It's very, very important slide because insulin to be used depend on the patient total daily dose of the insulin as an OPD. If the requirement is less than or equal to 60 units in 24 hours. So current sugar is if less than 70 or 70 to 100, there is no insulin requirement. And if the sugar is less than 70, give the 100 ml of the D10 water over the 10 minutes, followed by 50 ml per hour continue infusion. And if the sugar is 101 to 130, give the 1 unit bolus IV. 131 to 160, give the 2 unit bolus. 161 to 190, give 3 unit bolus IV. And 191 to 220, give 4 unit bolus. And more than 120, give 5 unit bolus IV. And the basal unit per hour is 0.5 units. And according to that, you can up titrate and down titrate the blood sugar and you can do the unit as per the requirement. If less than 70, there is no requirement, and decrease in the basal requirement 0.5 units per hour. If sugar is 101 to 130, you after that, if the sugar is increasing, then you can add the 1 unit per bolus and increase the 0.5 unit per hour. If 131 to 160, you can give the 2 units bolus and increase the 0.5 unit per hour basal. If sugar is 161 to 190, 3 unit bolus you should give and up titrate the 0.7 unit per hour basal. And if more than 220, 5 unit bolus IV you should give and basal 0.5 unit increase per hour. Same if Our OPD requirement is 61 to 120 unit per hour. The basal requirement is 1 unit per hour. Same according to that, if the OPD requirement is 121 to 180 unit per 24 hour, basal requirement is 1.5 unit per hour. And according to STEL, you should give the bolus units. And after that, you can up titrate and down titrate the blood sugar level. And according to that, you should give the insulin. If requirement is more than 180 units per 24 hour as a OPD, so you should do the 2 unit per hour basal requirements, and according to STEL, you should do the bolus unit IV. If the patient on the continuous subcutaneous insulin pump, if less than 70 blood sugar level, glucose D10 water 100 ml in 10 minutes given, and insulin basal rate reduced by 20%. If sugar 70 to 100, the glucose D10 water is due 50 ml per hour, and sugar is 101 to 150. There is an increase in the 20% in the insulin basal rate. So what are the management of the peripartum diabetes? Vaginal delivery is preferred. Cesarean section should be done only for the obstetric indication. During the labor and delivery, monitor the glucose level 1 to 4 hourly and maintain in the range of the 70 to 110 milligram per DL. In the later stage of the labor, started the DNS to maintain the basal nutritional requirement 100 to 150 ml per hour. And post delivery, keep the patient on the DNS till the feed, and no insulin should be given unless the glucose is high. So another parameter is GDM. It's very, very important because what is GDM? Gestational diabetes, it is a glucose intolerance of any severity with onset or first recognition during the pregnancy. According to FIDO in 2015, recommend that hyperglycemia first detected at any time during the pregnancy should be classified either as the DIP, diabetes mellitus in pregnancy, or GDM. There is a universal approach. Asian Indians are a high-risk ethnic group for development of the diabetes. So all pregnant Indian women need to be screened for the GDM. So when to screen for the GDM? GDM usually developed during the late pregnancy after the first trimester. However, if the screening is delayed till that time, there is a chance that pre-existing diabetes may be missed. So it is ideal to perform the first screening as early as possible during the first antenatal checkup. And when to screen? According to ADA, as early as possible in the pregnancy, and if negative, retest between 24 to 28 weeks. And according to DIPSI guidelines, the first screening at the first visit, and if negative, repeat at 24 to 28 weeks, and then at 32 to 34 weeks. And their main 2 guidelines was with the IAD-PSG performed at 24 to 28 weeks of the gestation, 75 gram glucose 2 hour OGTT use, and according to that, fasting more than or equal to 92 milligram per deciliter, 1 hour is more than or equal to 180, and 2 hours more than or equal to 153. It's GDM, and very, very informative and very useful is the DIPSI criteria for diagnosis of the GDM. In that test, 75 gram glucose load and sample collected at the 2 hours, and the value of more than or equal to 140 milligram per deciliter is diagnostic of gestational diabetes. So there is a proposed guideline for the screening for the GDM in India. If the fasting less than 92, it's non-GDM. 90 to 125, it's GDM more than 126, and HbA1c more than or equal to 6.5, it's over diabetes. So what are the main risk factor for the GDM? If age more than 25 years, if patient obese, BMI more than 25, waist circumference more than 80 centimeter, there is a family history of diabetes, previous GDM or glucose intolerance, previous macrosomic baby, member of the high ethnic group like Asian Indians, Pacific Islanders, and there is a PCOD, previous polyhydramnios, and previous unexplained perinatal loss or birth of a malinformed infant. So what are the implications of the GDM? There is a 2 maternal and fetal. So what are the maternal implications? There is a one very common preeclampsia, polyhydramnios, operative delivery, perineal trauma, and risk of the future diabetes. And what are the fetal and neonatal implications? There is a fetal macrosomia, birth trauma, prematurity, RDS, neonatal metabolic complications like hypoglycemia, hyperbilirubinemia, hypocalcemia, and polycythemia. obesity and diabetes in the later life. Is very common neural tube defects, sacral agenesis, caudal retractation syndromes. It is a more specific but rare manifestation of diabetic embryopathy, and it is a caudal retractation syndrome, fetal expelled at the 14 weeks, showing the absence of the sacrum and lumbar spine, and this is a metrostomia. So GDM and risk of the future diabetes in the offspring, because infants of mother who had diabetes during the pregnancy have a high risk of the developing obesity, IGT, and type 2 diabetes and other adverse metabolic parameters in the future. And the offspring of the women with GDM are at 4 to 8 times at high risk of the developing type 2 diabetes. So what are the management of the GDM? And there are therapeutic options. First is MNT, medical nutrition therapy, exercise, and insulin. This is a very important glycemic target in the pregnancy. According to ADA, fasting should be or equal to less than 95, 1 hour less than or equal to 140, and at the 2 hours less than or equal to 120. And according to DIPSI, there is a fasting less than or equal to 90 and 2 hours less than or equal to 120. And therapy is the very, very important. Insulin is the most standard treatment. Regular human insulin, NPH, rapid insulin analog like Lispro, Aspart, premix insulins, long-acting insulin analogs, and insulin glargine can be continued during the pregnancy if patient is already on it. So what are the dosage requirement of the insulin? The dose of the insulin is trimester specific. Insulin dose need individualization based on the carbohydrate content of the diet. Start with the low dose depending on the blood glucose level. Titrate frequently till the target level are achieved, and titration frequency should be guided by the severity of the glycemia. And dosage of the insulin normally increase as the pregnancy advances till the 35 to 36 weeks of the gestation. If the fasting sugar level are high, the woman we may need to put on the basal insulin at the bedtime. And after lunch or after dinner or postprandial or higher level side, short-acting insulin may need to be added before this meal as well. Basal bolus regimen may be needed to achieve the optimal glycemic target during the pregnancy, more often in the pre-existing diabetes. And insulin analogs are the evidence for the safety and efficacy of the insulin, Aspart and insulin Lispro in the pregnancy, because there is a minimal transport across the placenta and there is no teratogenesis and there is a good clinical efficacy. Rapid-acting analogs may be a useful alternative to regular insulin, particularly in case where the postprandial glucose value are very high and where the late post-absorptive hypoglycemia is an issue. There is a long-acting analogs so the insulin detamir is now approved for the use in the pregnancy, and recent studies showed there is a low rate of the transplacental transfer of the glargine. So recent meta-analysis has shown there is no evidence of the adverse fetal or maternal outcomes in the women who use glargine off-label during the pregnancy. So by that, I conclude my slides. Women with diabetes in the pregnancy need good control irrespective of the type of the diabetes. Antepartum control of the blood sugar is necessary to achieve a good peripartum control, which reduce the risk of the neonatal complications. The judicious use of the insulin is the key to have a normal delivery of a healthy child and to prevent the neonatal hypoglycemia. Postpartum counseling for the lifestyle modification in the future is very important for the future prevention of the type 2 diabetes in the women with the GDM, and the good control of the glucose level in the mother can significantly reduce the adverse pregnancy outcomes in the GDM. Effective control of the GDM reduce the fetal mortality to the same level as that in the non-diabetic pregnant women, and all pregnant women in the India should be screened for the diabetes, and the first screening should be take place at the first antenatal visit. Thank you.
Thank you, Malay sir, for this wonderful talk. It was very informative and very insightful. We have one question for you if you like to address it right now.
Please.
Can type 1 diabetics give normal delivery or surgery to the child, and will there be any complications?
Yes, very nice question. Yes, definitely. type 1 diabetes can give the normal delivery or surgery to the child and there is no any complication. But the main important parameter is the sugar control. I already mentioned, if the pre-existing diabetes and the type 1 diabetic patient should control their blood sugar level in their normal range. If the fasting postprandial level should be normal during the pregnancy, so there is a less teratogenicity to the offspring and to the baby, and there is a future maternal and even fetal and neonatal complication are very, very less. And there is she can deliver the baby with the normal delivery, and there is no any complication in the future. But the main aspect is the glycemic control. Yes.
That is why we advise the patients to plan it further.
Yes, and for that there is a according to DIPSI guideline, fasting should be less than 90 and 2 hours less than 120 during the pregnancy. And the basal bolus regimen is the ideal during the pregnancy and to control the HU blood sugar control.
Thank you, sir. We'll welcome our next speaker, Dr. Sushil Patel. Dr. Sushil Patel from Baroda is a consultant diabetologist at Akshar Diabetes Center. He has been awarded Best Consultant Diabetologist of Baroda, Executive Member of Research Society for Studies of Diabetes India, Gujarat Chapter, Member Secretary of Ethics Committee, All India Institute of Diabetes and Research, Program Manager of Stop Diabetes Program, Speaker and Chairperson at various CMEs related to diabetes, Life Member of RSSDI and Indian Medical Association, 9 years of experience in the field, conducted more than 180 diabetes awareness education and detection camps, taken more than 650 diabetes awareness lectures in public. Over to you, Dr. Sushil.
Thank you, Dr. Tajani, for this nice introduction, and thank you, Dr. Bansi Sabu sir, and our own friend, Dr. Vipul Chawda, for giving us this opportunity. And thank you to the Sanofi team also, so that we are all together over here. So let us not wasting the time. We have the wonderful session going on, the insulin in the special situation. I'm talking about the insulin in the elderly population. So why it is different than the other management of diabetes, like in the younger people, type 1 diabetes and the type 2 diabetes, but less than 60 years of age. So the only worthwhile pursuit in the life is the happiness. So when you are managing the patient, those who are specifically elderly patient, the happiness or the comfort of the life is a much more important thing than the sugar control. So what is the definition of elderly patient? Conventionally, elderly has been defined as the chronological age of more than 65 years of or older. And those from the 65 to 74 may be called as a early elderly. And those over the 75 years may be called as a late elderly. But the age predisposed to the diabetes, aging is as a process which is associated with the decline in the beta cell function. And the lower the blood glucose, lower the blood insulin level is independent of the insulin resistance as the age is advancing. The risk of developing type 2 diabetes increases with the obesity, lack of physical activity, loss of muscle mass, and all of which is going to develop as the age is advances. Older the patient who are lean secreted markedly less insulin in response to the glucose load, but have relatively less insulin resistance also. The patient who develop the type 2 diabetes in the older age are more likely to have the near normal fasting, but the significant postprandial hyperglycemia, and that can be the reverse is also true for some of the patient. So why we are talking about this topic right now? Because we are now getting the more and more number of the patient as the age expectancy is increasing. Now that we are having the more patients in the age group of 60 to 80 years of age. And in India, at 2010, there is around 15 million patients, and the expectation is more than 30 million patients in the age group of more than 60 years with the diabetes. And As the age is advancing, after the 15 years of diabetes, almost 75% of the patient is going to require the insulin therapy, regardless of their sugar status, because there is a decline in the beta cell mass. So general principle remains the same for the management of these patients to control the hyperglycemia and its symptoms, to prevent and evaluate and treat the macro and microvascular complications, to teach the patient to manage themselves, to maintain or improve the patient's general health. But unfortunately, most of these guidelines or recommendations are based on the studies in the middle age and the younger diabetes. So what should be different from the younger and the older patient? So whether we should go for the tight control or the loose control, benefit of tight glycemic control should be weighed against the risk and the realities of the individual situation. So it should be the individualized therapy. Priority should be given the best quality of life that is possible rather than the best sugar control. So if you can get the best quality of life with the good glycemic control, then it is the thing what you want to achieve. So there is altered pharmacokinetics in the patients, like renal functions may be declined, the metabolism may be altered. The individual tends to develop increase in the body fat mass rather than and decreasing in the lean body muscle mass. There are the chances of the drug interactions or the drug absorption may be delayed. Protein binding with the aging process is delayed. In addition to altered pharmacokinetics, older adults may also increase the sensitivity to medications through altering the pharmacodynamics or the homeostatic mechanism. Special consideration is needed for this particular age group, when we are talking about more than 75 years of age. Age-related changes in the pharmacokinetics. So already patient is burdensome, taking so much medication for the different complications. There may be some age-associated changes like the cognitive functions, visuals, physical function, dentition problem, taste perception. So it is always a difficult task for the patient to self-manage themselves. Frequent hospitalization may also required for different conditions. Comorbidities make the treatment more challenging. So the target for the glycemic control in the older adult, maybe if the HbA1c target is less than 7 to 7.5, you should target only in those patients where the longer remaining life expectancy is you suspecting, or there is no other complication. Then the sugar target may be 80 to 130 fasting and the 80 to 180 postprandial or the at the bedtime sugar. If the HbA1c is less than 8, it should be the target where the intermediate remaining life expectancy, high treatment burden, hypoglycemia vulnerable patients, or the patient with the risk of the falling. So the target may be somewhat loosened. HbA1c less than 8, fasting 90 to 150 is acceptable. The postprandial or the bedtime sugar 100 to 180 is acceptable. Where there is a very limited life expectancy, then avoid the reliance on the HbA1c in the glucose control decision should be based on the avoiding the hypoglycemia and the symptomatic hyperglycemia, where you should target 100 to 180 fasting or 100 to 200 of the postprandial sugar. So you should focus on this kind of patient the more in the quality of life rather than the sugar control. So insulin therapy, before prescribing any insulin to the elderly patient, we need to consider their visual acuity, manual dexterity, sensation, cognitive functions, support, financial situation, self-education. So all these factors should be in consideration before we are starting the patient on the insulin. Several studies have shown that the quality of life improves in the years after starting the insulin for the patients whose blood sugar was previously not in control with the oral agents. So the starting point of insulin should always be a basal insulin, where the fasting and the postprandial and the HbA1c all are high. If only you are getting the isolated postprandial sugar level that is high, then you may start with the once in a prandial insulin. Otherwise, the basal insulin is ideal one. So glargine, datamine, and the those who are the preferred insulin over the NPH insulin. Number of premix insulin preparations are available, and that is widely used in the India. They may improve the accuracy, but acceptability is good. But ease in the administration is there. But some patients are getting the frequent hypoglycemia with this, and there may not be the accurate control with the fixed dose regimen. So you may have to shift to the basal bolus or the basal plus regimen also. The frequent small titrated dose of short-acting insulins along with the long-acting insulin is always a cumbersome because the patient may have to take 3 to 4 times the insulin injection and they have to take check the sugar 4 to 6 times in a day. So what should be the ideal? First maybe the basal and then you may add to the basal plus, then the basal bolus. That may be the ideal choice of therapy in the elderly patients. So what should be the delivery device, pen versus is the vial? So most the insulins are available in the vials and pen, but the pen is always a better option for the patient because it is quick and easy to use. It provides the precise doses and can manage by the mainly elderly patients, while the filling the syringes with from the vial, this is a cumbersome process, and the patient may not having the accuracy of filling the syringes, and that may result into the various complications. So there are various studies are available where it shown that insulin pen are associated with lower risk of dosing errors and the hypoglycemia and the vial and the syringes. So dosing error is significantly low with the pen usage compared to the vial and syringe, and the hypoglycemia risk is again very much low because we are providing the accuracy in the insulin dosing. So pens are much better than the uh, vial and syringe. So how you can initiate or where should initiate with the insulin? So if the patient is drug newly detected diabetes, where the poor glycemic control more than 250 fasting or more than 300 postprandial, with the HbA1c more than 9.5 and having the symptomatic hyperglycemia, you should start with the insulin, but a low dose of the glargine may be the enough. Drug treatment or insulin naive patient if not in control with the 2 or 3 OAD, fasting more than 150, GB2S more than 200, HbA1c more than 8.5, or other comorbidities preventing the use of OADs, then you like the hyperosmolar non-ketotic coma that is more common in the elderly patient, diabetic ketoacidosis, acute myocardial infarction, unstable angina, patients treated in the critical care settings, patient awaiting the major surgery. There are so many other indications are also where you should start with the insulin. So the management of hypoglycemia in the geriatric patients with the diabetes, there is consensus guideline is also there, and it is again so the same thing that we use in the elderly diabetic patient. The basal insulin should be the initiation of, and it is simple to start at that bedtime. And there are various reviews are available with the basal plus insulin regimens also for the simpler insulin intensification. In the elderly type 2 diabetic patients in USA, early insulin initiation allows
There seems to be a problem with the net connection, Dr. Sushil.
Dr. Sushil? Yes, I think he is back.
Internet connection may have been a problem for him.
Probably.
We'll take up his questions from the discussion afterwards. We'll continue with the next speaker.
We'll wait for 2 minutes.
Okay.
Let him reconnect. No? We'll wait 2 minutes. And we can, I think, call him as well. Let me try.
Okay.
Yes, sir.
Meanwhile, I request all the attendees. If you have any queries, you can put your question in the chat box. Yes, Dr. Susil.
Hello.
Yes.
Sorry, it is disconnected.
No problem. Yes, you can continue. Yes.
I have to share the screen again. So dose at initiation, you can start with a low dose of insulin glargine. That may be the 0.1 to 0.2 units or the 10 units at the time, and is a reasonable first for the patient with the fasting hyperglycemia. The smaller the dose might be started in the frail or underweight or patient, those with the significant comorbidities. And there are different studies are also which is suggesting that you add the glargine once in a day along with the OADs. That may be more helpful than the basal plus regimen. Whether it may be the equivalently having the similar kind of HbA1c control and the black dot plus the OAD compared to the premixed insulin. And CO in that patients who are having the hypoglycemia is much lesser with the glargine compared to the so intensification of insulin intensifying the insulin where in the elderly patient then the regimen which are using maybe if it is glargine then you may increment the dose very slowly, maybe in the units of 2 only. When the target is less than 130, then you may add every 30 to 40 units increase like the 130 to 150 or 130 to 160 also you can take. Then 150 to 180 you may increase 4 units or more than 180 you may increase the 6 units. And when the patient is hypoglycemia less than 110 you may decrease the 2 units also. Less than 90 you may decrease the 4 units. Less than 70 you may decrease the 6 units of insulin. And when is the choice of adding the prandial insulin when you are having the good sugar control in the morning and but the HbA1c is not controlled, then you may consider to add the prandial insulin at major meal or according to the SMBG value. A combination of long-acting insulin and the prandial insulin is considered as an ideal regimen for the intensification since it mimics the basal and the prandial endogenous insulin. So addition of prandial insulin should be as low as 4 units per bolus dose or before each major meal. Each bolus you may add 0.1 unit per kg to start with, and the insulin regimen should be subsequently modified on the basis of individual response to the therapy. The safety and efficacy of basal plus regimen is already established when you are using the glargine and glulisin or even the fixed dose combination which is now available with the degludec and the aspart, that is the Rhizodec. They have the beautiful studies are available when you are using it once in a day only before the major meal of the day, and you may getting the good sugar control in the fasting and the post-meal. So it may be an option when you want to avoid the peak of the insulin, maybe the second or the third peak, you may use the Rhizodec once in a day or maybe the twice in a day according to the sugar level. So there are various reviews are available. Use of the basal plus regimen in person with type 2 diabetes stratified by the age and the body mass index, and it has shown that all the percentage of hypoglycemia is more or less similar, where the optional hypoglycemia is more prone in the elderly patients compared to the younger patient. So to avoid the nocturnal hypoglycemia, long-acting glargine like that is glargine U300 or maybe the degludec may be more helpful in these kind of patients rather than the NPH insulin or the routine glargine insulin. So to conclude the talk, you should start with low dose and you should gradually uptitrate. You should go very slowly in the uptitration of the dose. So growing old is inevitable. Growing up is optional. We should use the longer acting insulins, which is ultra long acting insulin Tresiba or the Tojo, that is glargine U300, maybe the first choice of the when you want to avoid the hypoglycemia. But you should take into the consideration the comfort of the patients and the education and the self motivation of the patient first when you are starting the insulin in the elderly patient. So again, thank you all of you. Thank you, Dr. Vipul and Bansi sir, for this nice opportunity. I hope that internet may not disturb the talk.
No, sir. Thank you. That was a very nice talk, sir. We are glad you could complete it. So we welcome our next speaker. Sir, we don't have any questions for you right now, but we have told everybody to put it in the chat box.
We have Dr. Vipul, sir.
Hello, sir.
Hi, good morning, Malai Tadni.
Yes, good morning, sir.
For our next speaker, we have Dr. Deepak. Dr. Deepak is a renowned diabetologist in Junagadh, founder of Hope Diabetes Clinic and Research Center, Junagadh, completed his graduation from Jamnagar Medical College and his post-graduation from A. Ramcharan Hospital, Chennai in diabetes. He is pursuing his PhD in Parul University. He finished his clinical research course from Oxford University. He has presented many national and international scientific papers in field of diabetes and has contributed as the co-author in diabetes textbook. Over to you, sir.
Thank you, Dr. Tarjini, for introduction. Thank you, Dr. Vipul and Dr. Bansi Sabu, sir, for this wonderful iSchool program, which is a need of now. And I'm sharing my slide. Let me know once it's visible. Is it visible?
No, sir, not yet.
The screen sharing has started, but the slides are not visible.
Maybe it will take some time because of network issue.
Yes.
Okay, thank you. So today we'll discuss about the insulin use in the patient receiving parenteral and enteral nutrition. So as we know, hyperglycemia in hospitalized patient who first diagnosed during hospitalization blood sugar more than 140 milligram. We have to rule out previously he was having any kind of type 2 diabetes or type 1 diabetes. Then we do HbA1c. If it is less than 6.5%, it is a stress-induced hyperglycemia or due to some critical illness, he is having a hyperglycemia. If HbA1c is more than 6.5%, suggestive of prior history of diabetes. If you see the prevalence of hyperglycemia in critically ill patient, almost 50% of patients who first time diagnosed with high blood sugar almost having a critical ill association of hyperglycemia. 22% having a recognized diabetes, unrecognized diabetes, who was having diabetes but first time recognized with more than 6.5 HbA1c, only 5.5%, and normal glycemia with 22%. So if we discuss about the parenteral and enteral nutrition, parenteral means if we are giving a nutrition with intravenous infusion, there is a two type of parenteral nutrition. One is the central and one is the periphery. If we give IV infusion nutrition with central line and with periphery, there are two types of parenteral nutrition is there. Enteral nutrition we give with some kind of external tubes. So very well known is the rice tube, which is a nasogastric tube, and most of we do feeding with that. But there is another types of tubes are also available, which is a nasogastric with nasojejunum, orogastric, orojejunum, some jejunostomy and gastrostomy is also available. So mainly two types. One is the parenteral with IV intravenous infusion, and one is with the tube, which is a eternal or external, we can say. So what is the burden of hyperglycemia in non-critical care setting? Approximately 46% of the non-intensive care unit hospitalized patients have diabetes mellitus either with or without prior diagnosis. So why nutrition and hyperglycemia is correlating? Hyperglycemia is a frequent complications of maternal and parenteral nutrition in both patients with or without diabetes, and that with development of hyperglycemia during nutrition support increases the risk of complications and mortality. Prevalence of hyperglycemia is reported in 30% of the patients receiving maternal nutrition and more than 50% patients receiving parenteral nutrition, because parenteral nutrition contains more of the dextrose than maternal. So what are the pathogenesis of hyperglycemia during hospitalization? We give IV dextrose in some parenteral and maternal nutrition, steroids, catecholamines, inflammatory states, cytokines. Then if we see absolute and relative insulin deficiency and increases the counter-regulatory hormone, which lead to lipolysis and glucose output and glyconeogenesis, and some protein breakdown, which lead to lactic and amino acid formation and decreases the glucose utilization in the muscle cell. So all this pathophysiology will lead to hyperglycemia, and in hospitalized setting, hyperglycemia will lead to circulatory and electrolyte effects like volume depletion, hypoperfusion, electrolyte loss, acid-base disturbance, some tissue effect like the reduced nitric oxide, superoxide generation, and so many things, which again lead to sepsis, multiple organ failure, and sometimes coma and death as well. So in patient totally reliant on the parenteral nutrition, means IV nutrition. These factors are compounded by the loss of the physiological incretin effect. We know what is the incretin effect. So if we give oral glucose effect, more of incretin secretion will be there, and which lead to decrease in hyperglycemia. So when we are giving totally parenteral nutrition, the loss of the physiological incretin effect on insulin release as occur when entirely bypassing the gastrointestinal tract with IV nutrition supply. Furthermore, the administration glucose stimulation increase insulin secretion in diabetic patient with some residual beta cell function increases the requirement of exogenous insulin. We are aware about that hyperglycemia and mortality increases the mortality. So what are the pros and cons of total parenteral nutrition? It improves the nutritional status and lower the hospital complications in critically ill patients with use of total parenteral nutrition. But excessive glucose administration during TPN may have a metabolic disadvantage manifested by accelerated lipogenesis in the liver and the fat tissue, increases the thermogenesis, and higher oxidation of glucose to carbon monoxide, resulting in increased work of breathing. So total parenteral nutrition has been associated with gut mucosal atrophy, overfeeding, hyperglycemia, and increased risk of infection complications and increased mortality in critically ill patient. So what are the clinical implications of hyperglycemia during total parenteral nutrition? Development of hyperglycemia during TPN is in hospitalized patient is independently associated with higher rate of mortality and hospitalized complications. Patients with hyperglycemia during total parenteral nutrition are more likely to be admitted in ICU, have longer hospital and higher mortality rates, require more prolonged course of parenteral nutrition compared with subject without hyperglycemia. Each 10 milligram of deciliter increase in the blood glucose above the reference value of 114 milligram per deciliter was associated with almost a 10% increase in the risk of infection and organ dysfunction. So 10 milligram increase in blood sugar increases the 10% risk of infection and organ failure. Prevention and correction of hyperglycemia via either modification of nutrient composition or by insulin infusion should be strongly considered during total parenteral therapy. So what are the glycemic targets during hospitalized patient? As per the ADA 2020, threshold for starting the insulin should be more than 180 milligram. Our target is 140 to 80. A string target with 110 to 140 milligram is appropriate for the subject if this can be achieved without significant hypoglycemia. The higher glucose range may be acceptable in terminally ill, severe comorbid when close nursing supervision is feasible. Our RSSDA on guideline says in the ICU setting, it should be up to 140 to 180, and non-ICU state fasting should be 80 to 120, pre-meal less than 140, and post-meal less than 180. So how we will manage in hospital? We all know insulin and OAD. OAD generally not recommended. Insulin, we give IV insulin and sub-Q insulin. In critically ill patient with ICU, we prefer IV insulin infusion, and non-critically ill patient, we go for a subcutaneous insulin. So why insulin is required during this parenteral and enteral nutrition? Because parenteral and enteral nutrition supports are provided in the number of ways, ranging from continuous to cyclic regime, often in combination with unpredictable and variable oral intake or additional intravenous glucose administration. Maintaining glycemic control is even more demanding in patients with unanticipated interruption of their feeding, or if a nutrition support is suspended due to accidental removal or obstructing of tubing. Strategy for maintaining a hyperglycemia to appropriate glycemic goal in patients requiring specialized nutrition support should be considered modification in the content of the feeding, as well as the initiation of safe and effective pharmacological therapy to reduce the blood glucose level. The mainstay of hyperglycemia management in the hospital is administration of insulin, given its high efficacy, flexibility, and lack of interference with most other pharmacotherapy or organ dysfunction. So which therapies insulin should be used? First of all, algorithm-driven IV insulin titration protocol during both parenteral and enteral achieved a superior glucose compared to subcutaneous approach with either sliding scale or basal bolus insulin therapy. So IV insulin administration is superior in compared to basal bolus sub-Q therapy. Administration of basal plus supplementation short-acting insulin analog, means basal plus basal and short-acting insulin analog, showed a superior efficacy compared to a sliding scale approach with short-acting. So if we are comparing, IV insulin is more preferable than sub-Q. In sub-Q, basal plus or basal bolus is more advantageous than sliding scale approach with short-acting insulin only. So how we different the formula to count insulin doses in diabetic person and in non-diabetic person. So add a insulin at a ratio of 1 unit of insulin per 11 gram of dextrose in patient with diabetes receiving a total parenteral nutrition containing 150 to 300 gram of carbohydrate per day. Rate of 1 unit of regular insulin per 10 gram of dextrose is used at a compensant of TPN infused in the diabetic patient, followed by a daily titration of insulin by 0.5 unit per 10 gram of dextrose if blood glucose target is not achieved. Glycemic goal during the TPN use in diabetic subject were achieved by insulin to carbohydrate ratio 1:4. In non-diabetic person, initiation of insulin rate should be 1 unit per 20 gram of almost double dextrose with further up titration to 1:15 ratio. And insulin to carbohydrate ratio 1:15 or average total daily insulin dose of 0.3 plus or minus 0.2 unit per kg per day. When we have an admixture of insulin into a parenteral nutrition feeding bag, what is the pros and cons? So administration of insulin into a parenteral feeding bag is a safe and effective alternative to use a sort of rapid acting subcutaneous insulin. But a lesser need of nursing time, the pros are the lesser need of nursing time, the concomitant discontinuation of insulin delivery upon a parenteral nutrition interruption, and the constantly lower risk of hypoglycemia event. So if we add insulin in the bag, it will have it will require a lesser need of insulin nursing time. There will be a insulin delivery if bag with the bag parenteral nutrition IV interrupted, then again insulin will not go. If we giving IV insulin different, not with the bag, then IV infusion of insulin will be started. And if the bag nutrition is interrupted, patient will go in hypoglycemia. So this is a benefit if we give insulin in itself admixed with the feeding bag. But
It requires a strict aseptic condition and may render the procedure impractical for not permissible as well. Reservation exists regarding the dismissal or highly variable efficacy of parenteral nutrition insulin due to interference from the parenteral ingredient or a bake surface material as well. So these are the cons. We are not very sure how much of nutrition and percentage will be there in different type of parenteral nutrition, and some ingredient of parenteral nutrition may interfere with actions of insulin, and sometimes the material of bag can interfere with insulin. So it is not that much recommended in our day-to-day practice. Role of CGM in, yes, it will give you an insight about how hyperglycemia trend to go, and each and every time we can have a trend of hyperglycemia and hypoglycemia as well. So it's a good tool to go with CGM in hospitalized patient as well. Role of basal insulin used in the hospitalized patient receiving maternal and parenteral nutrition. As we discussed, basal bolus is the main, it has an advantage over only a subcutaneous bolus administration on depending on sliding scale. Administration of an intermediate or a long-acting insulin can be recommended in parenteral and maternal patients receiving subcutaneous insulin therapy, with the required time to reach a steady state insulin level with long-acting formulation impose a certain constraint on the titration method and predispose to dysglycemia as well. So hyperglycemia in patients receiving specialized nutrition support, fear of hypoglycemia in hospitalized patients remains a major barrier in achieving an optimal glycemic control. We have discussed, Dr. Dharmendra has gone all this through, so we'll not discuss much about this, but the hypoglycemia can develop due to excessive insulin dose, abrupt discontinuation of nutritional support, recovery from acute illness, and decrease in the dose of glucocorticosteroid and vasopressin, and progressive organ failure as well. So this is all prevention of hypoglycemia we have to look after. So in the summary, if I discuss about the parenteral and maternal nutrition, with parenteral nutrition, it's better to start in a critically ill patient in ICU setting. Then we have to go with IV infusion. If dose is high or fluctuation is more. If fluctuation is not there, dose is not high, you can go with basal bolus therapy, subcutaneous basal bolus therapy with parenteral nutrition. In maternal nutrition, when you are giving nutrition with a tube every 2 hours or every 3 hours, my advice will be alternative carbohydrate and non-carbohydrate feeding should be there. So if you are giving one carbohydrate nutrition, then the second nutrition should be a non-carbohydrate or a very low carb nutrition. So whenever you are having a high carb or a carb nutrition, you give bolus insulin, and when you are giving non-carb or less carb, you tend to avoid or you check blood sugar, and depending on that you give bolus insulin and basal insulin again at bedtime or whatever a preferable time is there, that should be there. So this is the conclusion of my maternal and parenteral nutrition during ICU or hospitalized setting. Thank you so much.
Thank you, sir, for the talk.
Thank you so much, Dr. Dipak sir, for what you described. Yes, Dr. Please continue.
Are we having connected difficulties?
Yes, I guess Malay has some connection difficulty. Tadne, you should take over.
Yes. Now for the next speaker, we have Dr. Vipul sir. Vipul sir is a diabetologist and cardiometabolic physician, PG Diploma Diabetes Europe, PG Diploma Diabetes RSSDI, CCE DM, CCDR, CCMH, CCGDM, Chairman and founder of Rudraksh Institute of Medical Sciences, diabetologist in RIMS Health, Rudraksh Hospital, Maninagar and Bareja, District Coordinator, Ahmedabad RSSDI, National and Regional Faculty for Education of Healthcare Practitioners, Principal Investigator for numerous trials, author to national indexed publications and chapters. We welcome you, sir, and over to you, sir.
Thank you so much, Komati, for a kind introduction. Once again, I welcome all the participants to this iSchool 2022. We all are aware that this is a 100-year of insulin discovery, and still we are lacking in some link where we can provide insulin to all the patients who require insulin, not only in type 2 diabetes, also in type 1 diabetes. And as well as we have to do something to make insulin available at the remotest place of our country where there is so much diversity. The most important thanks goes to Dr. Bansi Sabu sir, who is the program director of this course and who is working tremendously to the awareness of diabetes. And by the program like iSchool and the program like Defeat Diabetes, he is doing so many things for type 2 diabetes patients. I hope my slides are visible.
Yes, please continue.
Okay. So we are discussing the special situations where we are using diabetes. There is a thumb rule for diabetes that when there is any complication or any infection in the body, the diabetic should be provided with insulin. And the reason behind it is that insulin is not only glucose controlling hormone. It is a hormone that is anabolic hormone for the body. It is a hormone which controls not only carbohydrate metabolism, but it has also effect on protein metabolism as well as lipid metabolism. So insulin is very, very important thing. Let's talk about dialysis patient. We all are aware that diabetic patient has a renal complication as well as cardiovascular complication, and we have that saying in medical field that the diabetic patient suffers from a CKD, but it died because of coronary artery disease. So in India, we have prevalence of coronary artery disease and CKD very much. About 48.4% of diabetic patient has CKD and 21.4% of diabetic patient has a coronary artery disease. So we have to do something for the patient who has such complications. Let's talk about effect of dialysis. What happened to patient when patient are having on dialysis? It clears many glucoregulatory hormones, includes insulin, glucagon, as well as C-peptide. It affects insulin secretion. It also affects insulin clearance. And there is a change in insulin resistance because of periodic improvement of uremia, acidosis, and phosphate metabolism after a cycle of dialysis. Glucose concentration in diacylate also influence the glucose control. When there is a lower concentration, it is associated with hyperglycemia. And when there may be a higher concentration, there can cause a dysglycemia as well. The dialysis may affect clearance of anti-diabetic therapies such as insulin or sulfonylurea and other anti-diabetic drug as well. So during dialysis and after dialysis, the patient of diabetes with CKD is at higher risk of hypoglycemia. So in that patient, we have to decide glycemic goal beforehand. And our target should be fasting sugar between 100 to 140. Postprandial should be less than 200. And HbA1c should be fairly controlled. We can say it should not be more than 8, but we should not keep target to control A1c below 7.5. We all know that there are various indicators for glycemic control, like blood glucose monitoring, HbA1c, fructosamine, and glycolated albumin. I must say that SMBG is one of the basic, one of the first, and one of the most important and reliable indicator for glycemic control in dialysis patient. And HbA1c, which gives a reason of at least 3 months glycemic control, is not a good predictive value, and it's a not good glycemic status indicator for the population who have a renal function very compromised. So diabetic management in CKD patient out of many available OADs, we all know that glipizide, repaglenide, and linagliptin can be used in renally compromised patients. But insulin is the treatment of choice for the diabetic patient with CKD. Preferably rapid-acting insulin analog with patients who have GFR less than 30 ml per minute, and basal insulin may or may not be required, depends on the glycemic status of the patient. Talking on for hemodialysis, on end-stage renal disease patient, insulin dosage may be reduced up to 50% at the what dose they were taking previously before dialysis. SMBG must be subsequently guide up titration of the insulin, and we must take care that there should not be any hypoglycemia. Certain key points have to be kept in mind on the day of dialysis. And this is the most important slide of my presentation. We must encourage our patient to monitor and manage their own glucose. They should not depend on our staff who are available at the dialysis unit, because they are not aware of the situation, what patients is suffering from in terms of glycemic management. Patients should bring their own insulin, their own tablets with them to the dialysis unit, and of course their own glucometer as well. In patient on agent that could be causing hypoglycemia, blood sugar should be checked pre-dialysis, also post-dialysis, and in some special cases during the end of the dialysis as well. Blood glucose can fluctuate during dialysis, and most frequent drops in the last few hours of dialysis, where all the OHA, all the insulin, and the glucose are washed out from the body. Reduce total insulin dose by 10 to 15% during or immediately following the dialysis is advised, and reduction in the dose of insulin as well as OHA is required when the patient has HbA1c less than 7.5 to avoid hypoglycemia. This is very important graph. What should be done pre-dialysis? What should be done post-dialysis? Pre-dialysis, if the sugar is less than 130, we should give 20 to 30 gram of carbohydrate prior to dialysis, recheck blood glucose level during dialysis, and at the end of the dialysis, we should provide some snack containing carbohydrate to prevent hypoglycemia. If the patient's blood glucose is between 120 to 300, there should be no action required. After the dialysis, if the blood glucose level is between 120 to 300, no action is required. But if post-dialysis, blood glucose is more than 300, ask the patient to monitor blood glucose and seek advice from the care provider, either a diabetologist or their special nurse, if the sugar is persistently high. If the patient is on rapid-acting insulin, the dose prior to dialysis should be reduced by 10 to 15%. Also, patients on premix or biphasic insulin, pre-dialysis dose of insulin should be reduced to 10 to 15%. And when the patient is taking a long-acting insulin pre-dialysis, the dose of long-acting insulin should be reduced by 25%. Nowadays, peritoneal dialysis is not performed too much, so we should not discuss about that because it is not in practice right now, because it was very tedious procedure. Intraperitoneal insulin was required, and it could be the core source of infection as well. With that, I will thank you all for your listening. Thank you all for joining iSchool. I am hoping that it is very helpful and useful in your day-to-day practice. Now, with this, I would stop sharing and ask the moderator to say something.
Thank you, sir. Thank you. That was an insightful talk. And thank you for organizing iSchool. It is really helpful, and it has always been very nice to hear speakers like everybody who has given wonderful lectures.
So with
Sir,
this,
we are open to discussion now. We request the participants to drop their questions in the Q&A section if they have any. Right now, there are no questions, sir.
Okay. Can I ask one question to Dr. Vipul, sir?
Yeah, of course, Malay.
Sir, what are the recent recommendation of SGLT2 inhibitors in seated patient, up to which eGFR we can use?
Yes, we can use up to end-stage renal disease. So there is no contraindication. We should stop adding SGLT2 when EGFR at the start of starting treatment less than 45. But if patient is already on SGLT2 and he develop end-stage renal disease or go to CKD, we must not stop, because it has a very multipotent effect on the patient for the not only glycemic control but for the renal protection and reversal of decreasing in EGFR as well. So we must continue SGLT2 if a patient is already on that, and up to 45, we should also initiate SGLT2 as well.
Yes, sir.
So I would request RX team, if we can take all the 55 participants into the main hall, then we can start the case discussion and making it very interactive. Because the purpose of iSchool, according to Bansi sir, is to discuss and have a live discussion how to use insulin, what are the case-to-case variation in that. And we have Dr. Bansi sir as well as Dr. Dhruvi and all the young brigades like Tarni, Komodi, and now Malay cannot be considered a youngster. He is now well established in the city of Rajkot. We also have Dr. Dharmendra, Dr. Deepak. We all are there. So if there is no question, Tarni,
Sir,
let's
there is
move to the
one
next
question from a person. Which drug should be used in renal compromised patient, and if glimepiride is safe or not?
Okay, I already answered that in my presentation, that there are a short-acting molecule should be used in renal compromised patient. In DPP4, linagliptin can be used in insulin secretagogue, repaglinide, and glipizide are very safe in the renal compromised patient. And we have Bansi sir here also. So let's take all the participants into main hall and start a case discussion. Dr. Dhruvi is also here.
So, Vipul, let us start the case discussion. Somebody had put in chat box a comment that whether these recordings will be available. So just to inform all of them that all those participants who could listen it, we are very much thankful to them. But these all recordings will be available on doctube.in as well as also on our Diacare website. For last year, iSchool recordings are also there with RX events, and we will put everything on doctube.coin. So just to inform everyone, and we will be also sending the link to all the registered delegates too. With this, if we can start the case, it will be great. Who is presenting the case? Yes, you can start.
Yes, sir. So, we have planned the cases in such a manner that our first case is going to be a very simple case wherein we've seen such kind of patients in our day-to-day OPD. He's a 63-year-old male diabetic presenting to our hospital with severe fatigue for the past 3 days. No complaints of frequent urination, no blurry vision, not much of a weight loss, tingliness, numbness in the hands and feet. He's unable to perform his routine activities. When we have taken a past medical history, the patient was on oral metformin twice in a day, oral glimepiride 2 milligram once in a day, and he has no history of hypertension or cardiovascular disease, no comorbidities basically. He does not exercise regularly, of course, has a sedentary lifestyle. He's a non-smoker though. When we did a clinical examination, BMI was 25, not so obese patient. Blood pressure 120/70, very normal. Pulse rate normal. RS was normal. No other, systemic deviations. Bilateral sensory loss in the lower extremities was detected. Now, of course, we'll, prescribe some investigations, and those investigations showed that his A1C was 9.4. A fasting PPVS was 220/310. Creatinine came to 1.1. Echo was also done, 67% EF, very good. Urine did not show any microalbuminuria, and fundus was also normal. Now, we start with the first question over here to the audience and to the panelists. So we start with our first question to the panelists. This patient who is only on sulfonylurea and metformin, what should be our choice further for an A1C of 9.4? He's a 63-year-old male patient, only with neuropathy, no comorbidities, no weight loss also. So only on 2 drugs, metformin and sulfonylurea. Anybody from the audience also wishing to give an opinion, we look forward to your opinions as well. Should we add a third OHA? Should we, wait and see what can be done? Or should we straight away start with a small dose of insulin? What do the guidelines say? Anybody having an opinion?
Guidelines says HbA1c 9.4, we start insulin. It's that simple.
All right. So the guidelines are saying OHA failure of more than 3 molecules, and then you start insulin. There are 2 parts to the guideline recommendation. So 3 or more OHA failure, A1C more than 9%, symptomatic patient, you can add basal insulin. That is what the guidelines are saying. What would you do in your real world practice? I know we are doing an iSchool, and of course the very obvious answer is कि भाई insulin चालू करी शो. But in our real world practice, what would
we start with SGL2? SGL2 and vidagliptin and metformin afternoon, and
this is an appreciative answer. Perfect.
And then metformin MRL in the night, and keep checking fasting blood sugar, and first bring fasting under control. That's simple.
So I just want to add here, Dhruvi, with any clinical case, a patient is in front of you. You have to see that what is your target A1C for this patient. So now this patient, let us consider that this patient should achieve a HbA1c of less than 7, and that is what our target is. As the A1C of more than 2.4 from the target is 7, and we want to achieve, and here it is 9.4. With sulfonylurea is already on board, which is most effective A1C reducing agent. So that is already been used in these particular patients. Now, as other experts and panelists are debating that we can add other things. Now, let us consider that you are adding 3 more drugs, a SGLT2, a DPP4, and the third drug which you can add here is alpha glucosidase inhibitor, which may be a commonest combination and prescription somebody would like to have. Now, if after adding these 3 drugs, let us consider in an individual basis, they can reduce 1.2, 0.8 and 0.4. This is if they are individually added as an add-on drug. So this will completely will be 2.4. But we had seen when in combination these 3 drugs are used, none of these 3 drug combination will able to reduce the HbA1c by more than 1.5. Here I am worried more because the patient fasting sugar is 210. Now, it's not only the guideline, even with your clinical experience with the patients on a sulfonylurea, if fasting sugar is more than 180, it is extremely difficult that you can achieve the A1C or fasting glucose less than 130 just by adding any molecule, because any of these molecules will not able to reduce the fasting sugar by more than 20. Even with the GLP-1 analog also, you will not able to reduce by more than 30 or 40. So the point is here, when I could not achieve fasting below 130, I will not able to achieve the A1C control of less than 7.5 or 7. So with the patients, even it is a 2 drugs and patient's sugar is not controlled, I will not go for 3rd, 4th, 5th drug. I may make it the postprandial should be better controlled with whatever the molecules. But here, it's just not because I am sitting here in iSchool and I am talking only on behalf of insulin. But this is the right choice that I will start with the patient on basal insulin. I will first try to achieve the fasting of less than 110. And we will add the molecule accordingly. The post-meal glucose level also get control, and less than 140 or 160 or 180 you achieve. Once glucotoxicity goes away, once the sugar is well controlled. When the patient is already on a different molecules, like you had put these patients on a Emeril MV1 3 times and once in a day, a SGLT2, and once in a bad time you are putting the patients on a Lentus. So you are actually putting a quadruple drug along with insulin also, but now everything is controlled. And after 2 months, if you start thinking, then let me stop insulin, let me reduce the dose of insulin, and you continuously reducing the agent as the fasting is getting good control, because as glucotoxicity will go away, beta cell function will improve, and there is all possibility after 2 or 3 months, patient may be off insulin. Patient basal insulin you started with him 15 units, maybe now after 2 months, 3 months or 6 months, his basal insulin is completely gone away. And now this patient's on those 4 drugs or 3 drugs or 5 drugs is very well controlled. So this is my clinical experience, that this type of patient, I would like to put the patient on insulin. I will see that what is the fasting. It is more than 180. There is possibility of putting him on any other drug. Will not able to achieve the fasting glucose control. But once we will achieve fasting glucose good control, the glucotoxicity will go away. And then there is always a possibility, you may tell the patient that 50% of the chance I may stop your insulin maybe after 3 months.
Thank you, sir. So that is the slide actually supporting your evidence that you are talking to us about, that early insulinization is of course going to improve the beta cell function. That is what our iSchool is meant for. That in a real world evidence, we would do something that Dr. Suryakant sir is already telling us. And I would say most of us would have done that, adding a third agent or adding a fourth agent. The evidence, like again, Dr. Pandit stated in the start, that the guidelines are saying that you start insulin and there is evidence. And how do we connect those guidelines, implementing it into a regular routine practice is what is the message of our iSchool, and that is what Dr. Banshi Sabu actually explained. So that brings us to my next, next continuation of this case. Give me a second. So now we've initiated glargine for the same 63-year-old male patient. He is continuing on the 2 OADs. Now, how do we titrate the insulin therapy? Banshi sir already said that we can down titrate or up titrate depending on the sugar levels. So again, I'm going to put up this open question to the forum right now. How do you think, once you've started glargine, say at somebody in the chat box also wrote that you start basal insulin at 0.2 unit per kg. That is how we are going to initiate our basal insulin. And say for this patient, we started it at 16 units. And we have a fasting sugar of say 160. We are quite far from the target. Our target fasting sugars are less than 120. Now, first thing we have to explain to our patient is what should be our target fasting to be achieved, target A1C to be achieved, and then what time do we want to achieve whenever we initiate a basal insulin. And at what time period of intervals should we be checking our fasting sugars. So generally, the practice is that you ask the patient to check the fasting sugars at every 3rd day, and ask them to either stay in touch with your team, educator, or the nutritionist, who then can plus and minus or up titrate or down titrate the insulin. After 3 weeks time period, the fasting sugar has come to 160, and the insulin that the patient is taking is 16 units. So let me again open the forum and ask, what should we do further? We have Umesh sir. Umesh sir, hope you're doing fine.
We increase the dose by 2 units.
Yes, Dr. Pandit. That is what we do. We generally up titrate the therapy, gradually up titrated by 2 to 2 units until on all we do not achieve the target fasting blood sugar control. Perfect. And again, I'm calling the patient, say, after another 3 weeks time period. And by this time, we've achieved a fasting of 82. The postprandial is 180. And since it has been 6 weeks, we are again taking the whole vitals again. We are taking the blood pressure, we are taking the weight, we are taking the BMI, we are doing a clinical examination, and also asking whether the symptoms of neuropathy have increased or whether they have reduced. So now at this point where we know that the fasting has come to 82 and our patient's insulin levels are 22 glycogen unit, how should we move ahead with it? When should we call the patient for a follow-up again? And how can we move further?
In case we are giving secretagogue, we have to stop that.
Okay.
We have stopped already. So we down-regulate the insulin level, and if you stopped Amaryl or any secretagogue, then the apoptosis has occurred because of hyperglycemia, which has now we have given the rest to the beta cells. So then the secretagogue may work now, and then we reduce the dose of insulin, and we instead of giving 1 milligram Amaryl 3 times a day, we can start in the 1 milligram in the morning and insulin glargine in the night at 10 o'clock.
All right. Thank you, Dr. Pandit, for your opinion. Can I have any other opinion? Dr. Malay, Dr. Umesh, sir? Umesh, sir was on mute last time he was trying to talk. And
I'm fine. Stay safe. We can reduce the dose of sulfonylurea and we can increase the dose at basal level gradually every 2 or 3 days, 1 or 2 units, depending upon the fasting level. Once we achieve until the fasting comes to 120 milligram %. So if the patient is educated, daily they can perform everyday fasting, send to the diabetologist, and according to that, we may increase 1 or 2 units every day also until the fasting comes to 120, 130.
Dr. Malay?
Yes, 20. Yeah. Sorry, said very well.
Okay. So we all agree, I think, to the opinions that Dr. Gedia sir and Dr. Pandit and Dr. Malay are telling us that, of course, we can reduce the sulfonylureas now, and we can also down titrate the glargine doses very, very gradually, again by checking the fasting sugars at every 3rd day time period, trying to keep the fasting sugar levels between 80 and 120 because he's a 63-year-old male patient. So our targets are 80 to 120. We do not go on a very intensive target. That brings me to my actual 3rd case. The first case was an initiation. Second was an intensification. And we now talk about poor postprandial sugar controls. So this is now a 67-year-old diabetic male patient presenting to the hospital with complaints of severe fatigue. Again, the same kind of a history, but this time the patient is hypertensive also. And now let us see what kind of therapy that patient is doing. Okay. Almost similar kind of observed values, but this time the A1C is 8.1, fasting is 120, and postprandial is 340. Everything else is same and stable, and the patient is doing very good. You've already started this patient on glargine. You have, controlled the fasting levels, down titrated everything, and the person is only on 6 units of glargine. You've taught him self-monitoring, he's doing, and now the only concern is his postprandial. What can we, do? How can we move ahead with this patient?
Yeah. Can I?
Yes, Malay.
Yeah, because we know India is a carbohydrate-centric diet. We all have Gujaratis, the sweet and chapatis. So first and most is the diet control, right? So because of only with diet you can achieve the postprandial control. But if still diet and lifestyle is not achieve your control, then you can use the postprandial anti-hyperglycemic agent like Linites, AGI, and yes, definitely you can use the bolus insulin also.
Absolutely agree. So we have a lot of options in our pocket when we want to control postprandial hyperglycemia. Gedia sir?
Yes, already there was a slide that patient duration diabetes is 11 years and his BMI is 23. So I don't think so that this patient will respond to the AGI because they will need now after 10 years of duration of diabetes, they will require the insulin therapy. So they are only being controlled with the short-acting insulin, and either you can use Actrapid or Glulisine or Novorapid like that. either 2+1 or 3+1, depending upon the 6 sample of the blood sugar. And according to that, you can add the insulin to control until the fasting comes to 120 and PPBS 140 to 180, because his already duration of diabetes is there, hypertension is there, whether he was working or not working, retired, depending upon the frailty, we can strategize the level of postprandial blood sugar.
Madam, his blood visual reflects his blood sugar is not under control. Indirect evidence we get it. So we give gliptins before lunch and then Rhizodec, which will take care of his post-breakfast and post-lunch and including post-dinner also till next day morning blood sugar. So that will cover up Rhizodec with the short-acting and long-acting glargine combination. That will sound better. Thank you.
Again, it is on the discretion of the physician. You can actually give a trial and error of a gliptin addition before the lunch. And you correctly said you can give a basal plus regimen like we are talking about, having a glargine and a bolus insulin, or you can combine them with a degludec, idec, aspart co-formulation. The only point you'll have to keep it in your mind is monitoring for this patient when you are giving insulin, both basal and bolus or a co-formulation. Just ask your patient. He's a 67-year-old frail male patient who is having a blurry vision and having comorbidities now. So this is a patient you do not want to develop any kind of glycemic variability, or you do not want him to develop hypoglycemia. So always keep it in your mind. You can add a co-formulation, you can add a bolus plus basal plus regimen, you can add a gliptin, and of course it will benefit. Just ask your patient to keep monitoring. Diabetes control is very, very different in each region depending on the patient's individualized format. So now we've started.
One thing I want to say, if the lunch is larger than the dinner, then you can give Rhizodec just before lunch. And if the lunch is smaller compared to the dinner, then Rhizodec can be given at midnight. So that will cover the fasting as well as the post-dinner, because we don't have any mentioning of post-dinner what is the blood sugar level. And depending upon that, we can time the Rhizodec injection. Or we can give twice a day Rhizodec also, just before lunch as well as before dinner, to control the both postprandial as well as the fasting. Is there any comment of anybody? Anyone comment?
Dr. Kaumudi, Dr. Tarjini, Dr. Chavda.
Yes, ma'am.
Any comments on what you would like to do with this patient? All right. So what, the evidence-based therapy is asking us or recommending us to do is adding a prandial insulin. Along with glargine, you can either add a rapid-acting analog like glulysin, or you can add any other regular-acting insulin just before the largest meal or twice in a day before 2 large meals. And this patient was recalled after 3 months and after 6 months, and you can very well see I'm a very good A1C control, a perfect fasting, and a perfect postprandial control. So let's move on to one of our next cases. I think it is a repetition of all the case. All right. So now we are talking about a young patient and a post-cardiac event. So now we are talking about a 40-year-old guy who is a known diabetic male patient presenting to us with complaint of severe chest pain lasting for 24 hours. The pain was sudden in the onset and progressive in nature. And due to the persistence of the pain, of course, the patient was taken to the emergency department. He is a known diabetic, known hypertensive, on metformin, glimepiride. He's also on telmisartan. He was a chronic smoker, also consumes alcohol. Blood pressure 110/70, pulse 90, BMI 25. Again, it does not matter because we are taking this patient to an ER for his actual emergency management. And this is the ECG, which is showing a first degree AV block, low voltage QRS complexes, anterior wall MI, and he actually needs a coronary angiography suggesting of, anterior IV branch occlusion lesion 50% in the circumflex artery and in the RCA up to 50%. Creatinine kinase 1920, fasting 190, CPK-MB 25, postprandial 320, A1C 8.9, create 1.1. A 40-year-old guy presenting to us with an anterior wall MI, undergoing an angiography, having such bad laboratory analysis, really condemns us to first think of the acute condition rather than the chronic condition. Now, this patient being diagnosed with an acute MI with type 2 diabetes and hypertension undergoes, a percutaneous coronary angioplasty being performed. Now, how should we be able to prevent such kind of events of complications in our patients with type 2 diabetes? Now, what should be our treatment strategy, and how can we educate this fellow, and could this MI have been prevented?
Yes, madam. This is our day-to-day issues in our practice. First visit itself, you must advise patients to take care of their blood sugar, lipids, cholesterol, which is in our hand. And every 3 to 6 months, check your urine albumins. HB1AC, bring under control, cholesterol under control, and yearly checkup, 2D echo, stress test, and first visit itself, fundus examination. These are the primary things which are important, and if we control all these things, and most of us maybe in Ahmedabad or Mumbai are all family physician or who are learning diabetes, they are preventing it right, left, and center, I think.
Absolutely correct. All of us agree with you, Dr. Pandit. Gadia, sir?
Yes. I think patient should be warned before the start, because already patient is known case of diabetes, hypertension, and smokers. So his lipid profile is not mentioned over here, but I would say that if the diabetes is there and hypertension is there, equivalent to endothelial dysfunction, so their cholesterol should be less than target. At least they should be having LDL less than 70, and they should stop smoking also. And they should be given the statin as early as possible, because the duration of the statin is very important, as well as dose is important. If you bombard in the initial phase, patient may prevent atherosclerotic events according to that SCVD score also. So when the patient is already having hypertension and diabetes, they must be given the statin day first. That is my opinion, as well as even we see clinically also since years together, when we have already put the patient on statin since 10 years, the patient doesn't have any comorbidity.
Yes, sir.
So this means that in this time and era, we talk about a complete holistic care to a person. We don't just concentrate on the glucose readings. We concentrate on the person as a whole. We talk about diabetic dyslipidemia. We talk about hypertension. We talk about macro and microvascular complication. We screen them quite well at the correct amount of time at regular intervals. And we also educate the patient on when to come back for follow-up and when to re-screen themselves for these complications, to de-addict themselves. And there is this whole landmark trial of the Steno-2 trial, which was done in the early 1990s, which talks about a multifactorial intervention, that you cannot be, again, glucocentric, you have to be vascular glucocentric. And all the molecules that are coming out now, be it the SGLT2s or be it the GLP-1 analogs, or all the molecules are now having their own pleiotropic benefits, and that is how our choices for prescription for any type 2 diabetic is going to work upon, like that.
Legacy effect.
Exactly, legacy effect, of course. So we'll take just one more case with renal impairment before we close off. He's a 52-year-old man presenting to the hospital with shortness of breaths, pruritus, and pitting edema of the legs to the level of the knees. The patient has trouble sleeping and concentrating for the past 3 months. He has reported having recurrent episodes of hypoglycemia, poor appetite, and fatigue for the last 2 weeks. He's a middle-aged man, and his medical and drug history is showing 17 years of duration of type 2 diabetes. He's already on NPH insulin for the past 13 years, on metformin and glimepiride, 1 gram, on atorvastatin, on amlodipine. He has a family history of 2 of his elder brothers being diagnosed with renal failure. One of them died because of renal failure, and hypertension and diabetes run in the family. He is having history of smoking and alcohol in spite of knowing all of this. Clinical examination is showing a weight gain of 7 kgs over 3 weeks, pitting edema of bilateral extremities. His BMI is 31, heart rate 94, blood pressure 165/92, RR 26. CV examination revealed impaired renal perfusion, and the rest of the tests are unremarkable. These are the reports. Hemoglobin 8.7, creat 2.2, which brings our eGFR to 49, A1C 8.8, LDL 143, HDL 43, RBS 186, ACR 281, calcium 8.7, phosphorus 4.2, and PTH 77. Very, again, all deranged reports. BUN 37, creatinine clearance 58, cholesterol 279, protein 9.7, microalbumin 280. And this is the renal biopsy showing membranous nephropathy. So we all know that he is having a nephropathy CKD stage 3 based on all the laboratory investigations that we've seen. Now, our question is, whenever we have such patients with already pre-existing comorbidities, as diabetologists, or when our primary focus over here, when we are talking about diabetes, is what should be our course of treatment, or what should be our course of management? How do you decide what should you take care of first?
Madam, first thing, amlodipine can also give a pitting edema. We stop that. Glimepiride with CKD can give hypoglycemia. So we stop glimepiride. So we put on 3 times short-acting insulin and insulin guard in the night, and keep checking blood sugar every time, and stop smoking. Absolutely stop smoking, and keep monitoring his serum creatine, eGFR, and he needs a complete workup on heart also. He needs complete workup on heart, and the CKD can be managed. CKD, only the heart problem which remains, which cannot be managed at a primary care physician. CKD can be managed.
Umesh sir, your comments?
We have also assessed EPO and OSA.
Nephropathy and eGFR is so the CKD stage is 3A. So instead of amlodipine, I would like to change over the telmisartan, as well as adding on instead of glimepiride, I would like to add slow release glycoside, as well as I would like to add SGLT2 inhibitors, because it has got effect both A1C as well as the renal function also. And Dr. Suryakant Pandit already mentioned that cardiac workup must be done, because already patient is hypertensive as well as 17 years duration of diabetes. The patient might be having some a degree of any coronary things. So we have to check up the cardio also, as well as if the patient is having tachycardic side, you can add a low dose of beta blocker also to prevent the cardiovascular events. And as early as possible, patients should be put on high dosage of atorvastatin 40 milligram.
Yes, sir.
As well as the adding the SGLT to either DAPA or EPA depending upon. And regular follow-up is also there, because patient is already having microalbuminuria also. And we can have either basal insulin or Ryzodec at bedtime, and we monitor the patient 2 to 3 months. I think single injection may control with Ryzodec or basal glargine bedtime, depending upon the duration. Already patient is taking insulin also.
Gadiya sir, only thing, madam.
Yes, sir.
We don't know the electrolytes levels, so can we start statins? Hey, tell me certain, because if the levels of potassiums are high, and patient is already a CKD.
Already EGFR is just the CKD stage is 3A. Usually this patient doesn't have hyperkalemic side.
Yeah.
We should be watchful when the EGFR is less than 30, and when the CKD stage is 4 is there.
Yes,
because in clinical practice it is the usual scenario.
Okay,
when the EGFR comes to 49 or like, usually they don't have, but at least before you start the telmisartan,
yes, sir.
we should have a single report of sodium and potassium.
Yes,
both.
sir.
And as soon as we reduce the, or rather stop amlodipine, it may happen that edema fit will go away.
Yes.
We can add low dose of diuretic also, same Ditor, 10 milligram, reduce the level of weight, and then we can see in the follow-up also. Because this is not the time, I would say 3+1 just now, but once he is more experienced than me, then he can add his also opinion, what he is giving opinion.
Sir, should we also assess OSA in this patient?
We can have Glycinase we can add. It's a very short acting. Glycinase.
Yes.
That is the only short acting anti-diabetic.
Instead of that, Suryakant, I would like to say glyclazide is having lesser number of
yes, sir. Glyclazide. Yeah, absolutely, sir. Agree, sir.
XR preparation is better than compared to glipizide.
Yes,
because I am working in Siusa Medical College and I am HOD.
Yes,
the highest number of hypoglycemic event we see in the glipizide, then comes the glimepiride and then glyclazide. So even clinical practice also we see that the XR preparation of glyclazide is better in compared to short acting. If you want to use short acting, you can use repaglinide or netiglinide, it's okay. But glipizide, we see hypoglycemic event is more in compared to glyclazide.
Okay, sir. Thank you.
Your comments, Malay?
Yes, sir has explained very well. And patient at CKD, so we should caution in the use of the metformin also, because patient on the 1000 milligram. So that's, we can reduce to 500 milligram also, and we can add the sodium bicarbonate also. And the ideal therapy is the insulin in the CKD patients. So,
Malay. Hello, Malay.
Yes, sir.
Yes, sir.
Reduction in the dosage of metformin doesn't required until 30 EGFR.
Yes,
if the patient is having symptoms of either vomiting or nausea or loss of appetite, then already patient is already on metformin 1000 milligram and doesn't have any signs and symptoms of CKD, I would not like to reduce the dose of metformin. You can give up to 1000, even 30 EGFR if the patient is stable. But if the EGFR is less than 30, nephrologists also they are giving sometimes 500 OD. If the patient is stable, taking good amount of diet, no loss of appetite. So here I would like to say that there doesn't require any reduction dose of metformin, because 49 EGFR is not that much of CKD. Definitely creatinine level is 2.2. We see 2.2, but EGFR is 49. So I don't think so. Patient doesn't have any symptoms of any CKD. It is an accidental finding probably. Dhruvi can throw any light.
So these are all made up cases. So it cannot.
Yes, yes.
I think we just made it.
Yeah,
That
not
is
real
a CKD stage 3.
Thank you, sir. Thank you. Thank you, sir.
So after such wonderful treatment by such wonderful experts, there was no further hypoglycemia in our patient. We
Thank you, sir, for your
A1C to
lot of
7.
years experience, sir. For experience sharing, sir. Thank you, sir. Thank you.
Thank you, sir.
Sir, thank you so much, Dr. Gadia, sir. Thank you so much, sir.
Thank you, sir.
So we've really treated our patient well. Creatinine has come down to 1.4, weight to 80, A1C to 7.2, no further hypoglycemia. And so that brings me to the end of our cases today. And it was wonderful having Gadia, sir.
One suggestion in this patient,
yes, sir.
that they should be screened for renal artery stenosis.
Yes, sir.
Because already patient has crossed 70 years, already patient non-hypertensive, patient diabetic, as well as patient is smokers, alcoholic. One should search for the this thing, and it is better to do the renal Doppler also.
Yes. Thank you, sir.
So when you see this type of patient, just refer to Umesh, sir. Nothing.
No. We can send to Sivasa Medical College, no problem.
Just short and simple for the record viewers, sir.
Dr. Dhruv.
We are having dialysis center also, and it is absolutely free.
Superb, sir. Superb.
Dr. Dhruv, you spoke very well yesterday on insulin pump. One of the best I heard so far. And I wish some workshops are kept for the doctors to know more about it. Like Dr. Sabu sir and you are saying insulin resistance, it works. What the way Bansi sir has said, if you are confident, it works. What the way Bansi sir has said about education is just fantastic. It's one of the best. One of the best. I liked it very much. And your lecture also.
Thank you, sir. Thank you. Thank you, Dr. Pandit. Thank you, Dr. Geria. We've really made this session very interactive. And thank you, Malay. Thank you. It has been wonderful. I'm going to request now Dr. Malay and Dr. Vipul Chavda to, give their closing remarks.
And thanks to Dr. Dhruvi for wonderful guest discussion.
Thank you, sir. Thanks, everyone.
And thank you, Umesh, sir.
Thanks, Ahmedabad High School. Thanks, Ahmedabad High School. Interesting things. Interesting.
If Bansi sir is there, we can have few words from him.
Vipul, you also spoke well on dialysis.
Thank you, sir.
Short and sweet, to the point to the doctors.
Yeah, you said very rightly, sir. When the doctor is confident, anything can be possible.
Anything can be done, yeah.
Yes. What happens to us that we consider any movement towards our goal as an achievement.
Yes.
So movement is not achievement. Until we do not start insulin to the patient, we should not put our arms down.
Yes, sir.
Sometimes in the constant of timing, sometimes the patients are waiting outside, we put our arms and we let the patient do whatever they want. But with the senior like Gedia sir and Bansi sir, we have learned that it's our moral duty to write the best prescription. I heard Bansi sir saying that if the patient is not taking insulin, he will not write anything. If you want to treatment from me, you have to take whatever I am writing. So that kind of confidence is needed in a physician who are dealing with
simple, basically the right side of the ethical side. You should be on the right side of the ethical practice.
And we have the young dynamic doctors from Bansi sir's team. Dr. Tarni, what's your call about insulinization in India?
Yes, sir, it is very necessary. Clinical inertia needs to be removed. In patient retention, we tend to not give or delay the process of introducing insulin, but it is very essential, and seminars like this help a lot.
Yeah, to boost up the confidence of all the practitioners, right? Malay, you give your closing remark and then the time is over, so we should close the session.
In day-to-day practice, we just received the prescription like metformin 2500 milligrams and glimepiride up to 8 milligrams, pyridoxine up to 45 milligrams, AGI, DPP, SGLT, all are, but not insulin in the prescription. So ideally, insulin as early as possible, you should use the insulin in your day-to-day to prevent micro as well as
પ્રોબ્લેમ એક જ છે પ્રોબ્લેમ એક જ છે કે બધાને બીક લાગે કે પેશન્ટ જતું રહેશે એટલે બધું ખેંચા કરતું હોય છે. That is not clinical inertia. એકલું કઈ ડોક્ટર જવાબદાર છે એવું નથી. તમે ઇન્સ્યુલિન લેવા માટે 1 વર્ષ પહેલા તૈયારી કરવી પડે કે આને મારે વર્ષ પછી ઇન્સ્યુલિનની જરૂર પડશે તો વર્ષે લેતો ગેરંટી નથી એ વખતે તે. They will change the consultant. I am very strict. If વિપુલે કીધું એ પ્રમાણે 5 વર્ષથી એક વખત એમ કે મારે ઇન્સ્યુલિન નથી લેવું એટલે કેસમાં લખી નાખવું ઇન્સ્યુલિનની જરૂર છે તો ગામમાં બીજા 15 ફિઝિશિયન છે શોધી લે. Patient will change the physician very next day or same day also.
Yes.
So this is પણ હવે એથિકલી ને આપણે વાત કરીએ છીએ પણ પ્રેક્ટિકલી માણસોને ગમતું નથી હોતું ઇન્સ્યુલિનનું જેવું કયો તો 1 વર્ષ પહેલા તૈયારી કરો તો કદાચ 50% પેશન્ટો લે. બાકી till today also we finding same thing કે ભાઈ ઇન્જેક્શન જે લેવું નથી તમે ગોળીએ જેવો ટ્રાય કરો એવો કરો મોંઘી દવા લખો બધું લખો તો ખબર છે કે 23-22 BMI એનું લાડામાં કશું થવાનું નથી તો લોકો વર્ષ 2 વર્ષ ખેંચતા જ હોય છે. પેશન્ટને સાચી વસ્તુની સમજણ જ નથી કે સ્પેર પાર્ટ બગડ્યા પછી કેટલા પૈસા ખર્ચવાના છે એ કોઈ જોતું જ નથી. ખર્ચા સ્પેર પાર્ટ બગડ્યા પછી બધું કરશે પણ બગડતા પહેલા તમારે જે સુધારવાનું છે એ they do not like to improve themselves also.
ત્યાં સુધીમાં બહુ મોડું થઈ ગયું હોય છે સર.
હા બહુ મોડું થઈ જાય છે પણ હવે પેશન્ટને ક્યાં ટ્રેલર દેખાય છે? આપણે પિક્ચર પહેલા ટ્રેલર જોતા હતા એને ક્યાં ટ્રેલર દેખાય છે? આપણને ટ્રેલર દેખાય છે કાનું આ થવાનું.
Well said, sir.
The truth,
Sir,
the
very
reality.
well said,
Very
and
well.
your experience of so many decades are into this 3 or 4 minutes discussion. That patients are not investing in the future; they want the
Yes.
comfort in the present, but they are not seeing the discomfort in the future. There is also one question or comment from Dr. Ratan that should we assess OSA? Yes, definitely. In obese patient, the OSA must be assessed because it may be the reason of uncontrolled diabetes, uncontrolled hypertension, as well as some cardiac and carotid issues. So yes, we must assess the sleep apnea in the obese patient.
Last patient case, last case presentation. OSA is a must.
Yes, it is. It is must. Yes. So with that, I would personally thank you all the participants to make it very interactive. I hope that this iSchool will make a difference into your practice and also affect so many patients that you are seeing every year. And we can make insulin more easily available, accessible, and useful to all the patients during this COVID era as well as after that also. Thank you all the speakers who make this session very, very useful and make very, very active and very, very informative for all the participants. Thank you so much, Sanofi. Thank you so much, all AMA as well as AFPA. And last but not the least, the Dr. Bansi Sabu sir, who conceived this concept of iSchool and is considering that it is very, very important to educate not only patient but also to the physician, and continuous medical education is the need for time. So this iSchool will be continue every 4 or 6 months, and let's meet once again in the next iSchool. Thank you
sir.
so much.
Thank you, sir. Very good day. Yeah.